developed after remission. Now, there are a few consistent predictors of relapse. An important negative predictor of relapse is if there's a precipitant, such as a drug or a virus. If the AIH has been precipitated and you withdraw the precipitant, relapse is very unlikely. But that's not the case for most patients with autoimmune hepatitis, where it just happens without a precipitant. There's some evidence that delay or failure in achieving remission or a raised transaminase or IgG at the time of stopping is predictive of relapse, and also in some studies younger patients, but it's an inexact science predicting relapse. Next slide, please. Does it matter? Does relapse matter? It can do. There's been several cases described of relapses being fatal, but nearly all of these cases, cirrhosis has already been present. There's reasonably good evidence that repeated relapses, which are defined variously as more than 2 relapses or more than 4 relapses per decade, can predict a poor outcome in terms of progression to cirrhosis and liver failure. But it's important to point out that 1 relapse doesn't seem to do. There's no evidence that 1 relapse per se is damaging. There's a very good response to retreatment of relapses. They nearly all go into remission again, but of course you need more steroid therapy, and people don't like that. So you try and the idea emerged early on that it would be good to try and prevent relapse. Now, most of the kind of research on this was done, I think, at King's College Hospital in London, and they tried various regimes to prevent relapse. And the best one, next slide please, was long-term azathioprine therapy. And this is a follow-up study that they published in the New England Journal in the mid-90s on, I think, about 78 patients. And they showed that on 2 milligrams per kilogram of azathioprine maintenance, so-called maintenance therapy per day, the relapse rate was reduced to about 17% over 5 years. Next slide, please. So the idea of long-term treatment, maintenance treatment for AIH, kind of took hold. And it was the kind of dominant, I think, treatment paradigm over a 30-year period between 1990 and 2020. If you look at lots of multi-center studies, you find that in 80 to 90% of patients, they were on a long-term, whatever that meant, steroid-sparing agent. There were lots of cohort studies, and it's sometimes hard to extract the data from the method section, but it did seem as if treatment in these cohort studies was only stopped in a minority of patients, about 20%, and most people continued long-term immunosuppression therapy. Even steroid-based, there was a study in the UK published a few years ago that suggested that over half of UK patients with AIH were on so-called long-term steroid therapy. Next slide, please. Now, this is fine, long-term immunosuppression, but you have to ask 2 questions. Is it effective? Does it continue to be effective in the long term? And is it safe? And I'm going to try and address both those issues. Next slide, please. We know that immunosuppression is not completely effective because some patients, I mean, in general, fibrosis is stable, or it can even improve on immunosuppressive therapy. But in a significant minority of cases, there is progressive fibrosis leading to cirrhosis in treated patients. The overall percentage is about 18%, and the actuarial rate over 20 years is about 1/3. Just think about that. This is a treated disease. If you had, I don't know, hepatitis C or B, and you said that on this treatment, only 1/3, I don't think you'd be very impressed, would you? But that is the situation with the standard treatment for autoimmune hepatitis. A minority of people will develop cirrhosis. The associations of cirrhosis development are failure or delay in normalizing the transaminases or recurrent relapse, essentially difficulty in controlling the disease. Next slide, please. So it's not surprising, because of some develop cirrhosis, that patients with autoimmune hepatitis, despite treatment, still have excess mortality. There are now 10 studies I found, including 3 national registry studies, and it is clear that the standardized mortality of AIH is about 1.7, right? It's still excessive. It's not just that some of them need a transplant. If you just take deaths alone, it's still excessive. It's over 1. And it's higher in patients with cirrhosis, unsurprisingly, and it is also higher in patients presenting young. It's a sad fact that if you present at a young age with AIH, your life expectancy is nowhere near normal despite treatment, right? And the excess death is probably due to, well, it's mainly due to liver disease. There's still no evidence that non-liver deaths are increased in AIH. Next slide, please. It goes further than this. There used to be this idea that AIH burned itself out after 10, 20 years. There's very few data after 20 years, but this is some data from Sheffield. We took 65 patients who we had already followed for 20 years, and we followed their subsequent progress in green over the subsequent 20 years and compared it with people presenting initially. And it's essentially the same. After 20 years, you still get relapse, you still develop cirrhosis, and you still have liver-related death. The disease, at least in our hands, does not burn itself out in the longer term. Next slide, please. Why the excess mortality? We know that some people don't go into biochemical remission. They don't do particularly well. I've already mentioned recurrent relapse, but I'm going to talk briefly about persisting histological activity. Next slide, please. So this is, again, data from Sheffield, some histological activity, the index. This is the Ishak score. Kamal Ishak was a famous Egyptian hepatopathologist. And so this is the Ishak score. In the blue ones are the initial ones before steroid treatment. And there's a wide range of them. The median is about 11, an Ishak score of about 11 prior to treatment. If you give them 2 years of steroids and azathioprine, it's dramatically improved, and the median's about 3. But you can see that there's a significant proportion that are not in full remission, i.e. they have an extra-inflammatory score of over 3. It's a lot better than it was. So does this matter? Next slide, please. Well, yes, it does. If you fail to reduce your follow-up Ishak necroinflammatory score to 3, you will have a poorer long-term outcome. This is an independent predictor of poor long-term outcome. Next slide, please. So I hope I've convinced you it's not fully effective long-term immunosuppression. It may be of some efficacy. We don't know how worse things would be if we stopped the long-term treatment in everybody, but it's certainly not fully effective. Next question, is it safe? Now, I'm not going to discuss these in detail. We know that you can get long-term marrow depression, sometimes after 20, 25 years of azathioprine therapy. You can get pancreatitis, hepatotoxicity, cataract, osteoporosis relating to steroids. I haven't time to discuss those, but I am going to discuss, next slide, please, the issue of cancer, excess cancer in AIH. It is now a fact that patients with autoimmune hepatitis have an increased risk of extrahepatic cancer. I'm not talking about hepatocellular carcinoma here. I'm talking about extrahepatic cancer. In about 6 studies, the median incidence ratio is 1.8 with a range of 1.3 to 2.7. This includes several specific cancers, including non-melanoma skin cancer, excess rate of over 2, lymphoproliferative cancers, colorectal cancer. Interestingly, it's not all cancers. That there's a consistent absence of an excess risk of breast cancer. Why is this? It's probably the immunosuppression. There is no evidence of an excess risk of cancer prior to a diagnosis of AIH in these patients. There's a large Scandinavian study that indicates that. There's evidence from solid organ transplanted patients of an excess risk of cancer. And in one recent study, this paper by Jensen in the American Journal of Gastroenterology, they attempted to establish a relationship with duration of immunosuppressive therapy, and there was a suggestion. So it probably is due to the immunosuppression. So much for azathioprine and cancer. Let's talk about diabetes and steroids. Next slide, please. This is our own data from Sheffield. It's well known that steroids cause diabetes. In our hands, in 262 patients who had no diabetes prior to commencing therapy with steroids, the incidence rate over 10 years was almost 20%. This is far higher than the base rate. And of course, it's dose dependent. It's higher in doses of more than 40 milligrams of prednisolone per day. I think one should be very cautious in starting high-dose steroids in patients with diabetes. It's done probably more often than it needs to be. Next slide, please. So, sorry, I will say one thing about the diabetes. One other thing. You might argue, well, we give them diabetes, we stop the steroids, it gets better. It doesn't always get better. In a substantial number, it seems to be permanent. Next slide, please. Apart from diabetes, there's weight gain. the BMI goes up by about 2 points on steroids. It's sustained in over half. It's much harder to lose weight than to gain weight. There are large database studies showing associations between steroid treatment and cardiovascular disease. And finally, there's the issue of hepatic steatosis. Next slide, please. Again, this is some pair data from Sheffield. That there are the prevalence of mild steatosis in AIH, diagnosed AIH, is about 25%. This is not surprising because about 25% of the general population have fatty liver. What's interesting is that it gets worse with steroids. You can see the shift. It becomes more prevalent and it becomes more severe on prednisolone therapy. We don't know what this means, but it cannot be good news that in giving people steroids, we are making their fatty liver disease worse. We need to look into the implications of that in the future. Next slide, please. So I hope I've dented the idea that, well, it may not be fully effective, and I hope I've kind of convinced you that long-term immunosuppression therapy is not completely safe in some patients. So I hope I've convinced you that you should at least consider the possibility of stopping treatment in some patients. But the question is who and when. Next slide, please. So let me remind you of this endpoint, complete biochemical remission. This is now being kind of touted as the best treatment endpoint. I have some reservations about this, but it's certainly out there as the best treatment endpoint. What we mean by complete biochemical remission is a normal serum AST, ALT, and immunoglobulin G, not just globulin, actual immunoglobulin G. This is achieved in between 50 and 75% of patients within 6 to 12 months. It implies that there is usually histological remission, that the evidence base for this is very low, actually, only 36 biopsies done in one centre, Hamburg, but in the majority, 75%, there is histological remission if you achieve sustained complete biochemical remission. Maybe more convincingly, there's for fibrosis stability on repeat biopsy. The fibrosis doesn't get worse. In a large group of patients with FibroScan, there is stability of FibroScan scores, in contrast to patients who don't achieve complete biochemical remission, where the FibroScan scores get slightly worse. And in more recent studies, I think I mentioned there, it predicts a lower relapse rate. And also in this Korean study, it predicts a low liver adverse rate. And finally, in this multi-center European study, there were the people that attained complete biochemical remission had a lower liver-related death rate. So it is a reasonable treatment endpoint. Let me share one other bit of data with you. Next slide, please. This gets back to the original of duration treatment. I was wedded for years, and it's actually the UK and EASL guidelines that you should treat with steroids and azathioprine for 2 to 3 years. We supervised a UK multi-center audit, which has just been published. And there were let me share you two things about this. We could not demonstrate any mortality advantage in continuing steroids beyond 6 months, nor could we demonstrate any survival advantage in steroids, continuing steroids after normalization of ALT. So my views about duration of steroid therapy have changed based on this and other data, rather than from automatically 3 years. Next slide, please. So, in stopping therapy in whom and when, my kind of recommendation would be that you should consider stopping, phasing out the steroids after you've attained complete biochemical remission for 6 to 12 months. It would be nice if you also had FibroScan evidence of stable or improving fibrosis. And ideally, you would have a liver biopsy, but accepting that that's not always feasible or appropriate. In regard to the steroid-sparing agents, there's even less evidence, actually, to base the guidance for this. The ASD and EASL liver guidelines suggest that you keep it going for at least 2 or 3 years after complete biochemical remission. And you would only stop in some patients. Next slide, please. I've tried to summarize the kind of patient where you would be inclined to stop treatment here. And I'll go through this briefly. If you have somebody over 40, that's a reasonable indication to consider stopping. In younger patients, it's a more aggressive disease, and I would be hesitant to stop immunosuppressive therapy. If there's an AIH precipitant, you really don't need maintenance therapy because the risk of relapse is so low. There are certain kinds of patient where you would rapidly achieve complete biochemical remission, or where the serum ALT is low normal, where the relapse rate seems to be low and it's reasonable to stop it. I must point out an error here. Cirrhosis, that should mean yes, not no. My apologies for the typo. If you have cirrhosis, you should not stop immunotherapy because of the possibility that they might decompensate with relapse and even die. So please correct that. If you have recent cirrhosis, no, you wouldn't stop. Cancer, recent cancer, you wouldn't stop. Because the immunosuppression might aid growth. The evidence after 3 years, in other words, if you've had a cancer and you're more than 3 years out from the cancer, there's actually no good evidence that continuing immunosuppressive therapy is detrimental in terms of the cancer. It's possible, but it's not been demonstrated to my knowledge. So you could consider it after 3 years. If you have vascular risk factors, that's a good reason to stop steroids when you can. If you've tolerated steroids in the first instance, it's reasonable to stop them on the basis that if you have to retreat a relapse, it mightn't be very problematic. It might, on the other hand, if you had somebody who was very poorly tolerant of steroids, you wouldn't want to give them have to restart them on steroids. And finally, we must remember patient wish. Patients often want to stop, and you have to, whatever the circumstances, you have to respect that. Next slide, please. Do you need a biopsy before you stopping? Now, the EASL and ASLD guidelines say you should do a biopsy. I'm not so sure, actually, because I'm not sure what extra information you get from it. Does it predict outcome? The histology is not very good at predicting relapse. That's one thing. It, as I think I indicated, may be of some value in predicting fibrosis progression, but of course you can use non-invasive tests here like FibroScan, and it may predict mortality. But the fundamental question here is, would doing a biopsy give you information that would lead you to change management? I suppose you might stop, you might not reduce the immunosuppression, but the question would arise then whether the immunosuppression is doing any good if they're not, for example, in histological remission. And because there are no trials of other second-line immunosuppressive agents, there's no kind of clear pathway from doing a liver biopsy to moving to a proven effective treatment. So I think a biopsy can be considered, but I'm not sure it should be routine. And of course, patients don't like biopsies. Next slide, and I think it might be the final. Actually, sorry, no. I thought I would share this with you. Actually, this is again some of our data from Sheffield. Sorry, can I just go back? Move forward one. Yeah, we have limited experience with this, but we did stop the immunosuppression in about 30 patients, and the relapse rate, if you stop people after 7 years of immunosuppression, seems to be lower than if you stop just after initially attaining remission. So the rate was quite low here after several years. But what's more important is that they didn't all die of liver disease. In fact, their outcome, their all-cause mortality rate was less than in patients who continued immunosuppression. Now, the groups aren't really comparable, but I think we can reasonably conclude that the outcome is not worsened, at least by withdrawing immunosuppression after several years. Final slide, please. So, to conclude, lifelong immunosuppression can be problematic in terms of, for all sorts of reasons that I've discussed. You should approach AIH with the idea of trying to avoid this. I used to think like this. I've changed my mind over the last 10 years. I was quite comfortable with lifelong immunosuppression. I'm not anymore. So you always keep in mind the option of stopping immunosuppression. But of course, the feasibility depends on the particular circumstances of the patient, the risk of relapse, the adverse consequences of a relapse. I think a biopsy should be optional. But the last message is, and this is really important, that if you do stop immunosuppression, you need to keep a close eye on them for both a relapse, and so you would measure the transaminases and the IgG, And you also need to somehow measure fibrosis progression, probably non-invasively. The most tested modality would be transient elastography. So thank you very much, and I'm happy to take questions. Sorry, that's just another slide showing that chloroquine reduces relapse rate.
Any questions from the floor for Professor Gleason regarding when to stop and immunosuppression in autoimmune hepatitis? Any inquiries? Apparently it was too clear. Thank you so much.
Thank you.
Move to the next speaker.
The next presentation is by Professor Martina Moller-Schilling, Professor of and the Chairman, Department of Internal Medicine, Gastroenterology, Pathology, Endocrinology, Rheumatology, and Infectious Disease, University Hospital, Rosenberg, Germany. Her main research area, B53 family, viruses, apoptosis, cellular immunology, and tumor development, machine learning, support medical decision making, and risk prediction. B53 family in bacterial defense and acute on chronic liver failure. Her talk is about acute on chronic liver failure.
Thank you so much for the introduction, dear Chairman, dear moderator, dear colleagues. As I said yesterday, it's very, very thrilling for me to be here and to attend your conference. And you really picked out the very, very important topics in hepatology that are really of global concern. Congratulations to this wonderful program. So it's on me to talk about acute and chronic liver failure today. And I apologize for having to leave after my talk, so I would appreciate taking the questions after the talk. I'm sorry for the tight schedule. This is the agenda. There are lots of definitions out, and I have chosen, in my eyes, the best for our clinical practice. We are going to review the concept of cirrhosis and decompensation. We are going to talk about prevalence and mortality. It's a global issue. And we're talking about treatment and intensive care. And so this is something that combines all of hepatology and all of intensive care. We distinguish between three versions of liver failure. So acute liver failure, as you all know, affects people like you and me who have a normal liver. And then there are people who suffer from chronic liver failure. And acute on chronic liver failure, you can regard this as the most dangerous form of decompensation. And we should keep a close eye on our patients to avoid this. So let me share the definition with you first. And as I said yesterday, for your convenience, I have added these QR codes so that you can scan them and have the literature available. And at the end of the talk, I will also send you, give you a QR code with my contact so that you can also email for the whole talk if you like it. So, acute on chronic liver failure is a clinically and pathophysiologically distinct syndrome which carries a high short-term mortality. And this is extremely important. It's a distinct syndrome. The diagnosis of acute on chronic liver failure is made when you have a patient with liver cirrhosis with acute decompensation and organ failure. This is the buzzword. And organ failure, you can define that either by the European guidelines, the Cliff-SOFA score, or you could also use the score of the American College of Gastroenterology. Both are good. This one predicts the 28-day mortality, and the one of the American College of Gastroenterology is more a predictor of futility. These two scores are better than the well-known child score and the model of end-stage liver disease. This is very important. So we have to get used to using these scores. The mainstay of the management, as I said, is organ support and treatment of the precipitating events. And it's always challenging to decide which of these patients should undergo liver transplantation. I still think this is the most challenging question in the clinical management of these patients. There you can see that we have to really describe this acute and chronic liver failure as an own entity with own prognostic scores, and that there's the Cliff-Sofa score and those, and this is shown here, and those, as I mentioned, of the American College of Gastroenterology that do better than the scores that we are used to apply in our clinical practice. So remember, new scores. Remember, this is where two large fields join. It's the hepatology field, it's hepatology, it's transplant, and it's intensive care. So do always have a watchful eye on your patients to really, really pick those out who are going into acute and chronic liver failure and send them to your ICU. So management of acute and chronic liver failure is best accomplished by a multidisciplinary team, and you need expertise in critical care and transplant hepatology. What we have to do daily is to look for the precipitating cause, to distinguish sepsis from delirium, and to support organ failure, and to select the patients for liver transplant. So this is a challenge. Let me go back to the pathophysiology and to the idea of this being a new an entity of disease. You know, this is the course of our patients. So they have chronic liver disease, it's pre-cirrhotic, and it's compensated for a very, very long time. Often the patient doesn't know he has liver cirrhosis. And then you have decompensation. And you should avoid this. And this is clearly, clearly important because decompensation can have various forms. I will show them later to you. And every patient who has decompensation is also at risk for acute and chronic liver failure. Remember, characterized by high mortality. So this is what you should keep. You should keep your patients in a compensated stage, because decompensation means your patient is going to live just for 2 more years. This is very, very important to have this in mind. So what's the paradigm change? So when I did my, when I did my education and I was a trainee at the intensive care ward, we were very, very much absorbed with the prevention of the dramatic complication like varicose vein bleeding. So that was our thinking. But we have to change that thinking. Liver cirrhosis is a systemic disease. It's much more than portal hypertension. And I'm going to show you this. So that paradigm shift was basically initiated through this study published in The Lancet in 2019, which clearly showed that beta blockers do not only prevent portal hypertension, but beta blockers, they appear to prolong the decompensation-free survival of our patients. And they do that mainly by reducing the incidence of ascites. So this is a key issue to treat your patients. Don't let them go into decompensation. Keep them on beta blockers and really do that good, because cirrhosis is so much more than portal hypertension. You see here, it's splanchnic vasodilatation, and it's bacterial translocation. And if you remember my talk from yesterday, you know how important the gut-liver axis is, the gut-liver-brain axis is going to be. So we have to think more in systemic implications and in the pathways that regulate systemic inflammation. So this is the new paradigm. have the patient in their compensated status measure liver stiffness and platelet count, because they are early indicators for a patient that's going to progress. So don't just concentrate on gastroscopy. That's almost out, because we need to catch these patients earlier. So liver stiffness and platelet count. And if you have signs of clinical significant portal hypertension, then use beta blockers and use them in the adequate doses. That's extremely important. Our new goal is to prevent not only clinical decompensation, but also ascites, varicose bleeding, infection, hepatorenal syndrome, and hepatic encephalopathy. That is really, really important. We have new goals. It's prevention of decompensation. And you have to catch that early, and my best recommendation is use liver stiffness and the platelet count. I have added this for you. These are the levels of evidence for non-selective beta blockers in cirrhosis. As you can see here, there is indication in the prevention of decompensation. That was what I talked about. Prevention of first variceal bleeding, prevention of variceal rebleeding, and not such a strong evidence you see here for gastric varices, and also an indication for portal hypertensive gastropathy. So if you follow the barcode, you can really have that nicely put together for your clinical praxis and to take it home. This is now very, very important. You have a patient. You know a patient has compensated cirrhosis. You monitor him or her closely by liver stiffness measurement and platelet count. And then there's this really important study that says there are different clinical courses of acute decompensation. And this is important to think about. There are 3 groups of patients. The first group has high systemic inflammation, and I come to you, I explain you where this comes from. Others have severe portal hypertension, and others have just less frequent complication. And this is the first group I have to draw your attention to, with high inflammation that is going to develop acute and chronic liver failure within the next 3 months. You have to select these patients. You have to find out what endangers them. Now we move to acute and chronic liver failure, because you have to know when it occurs. So you have to know the definition. Unfortunately, we still have many definitions, and worldwide these 3 are in use. You see the one of the Asian Pacific Association for the Study of the Liver on the left. In the middle, this of the European Association for the Study of the Liver. On the right, the North American College of Gastroenterology. But what do they all have in common? You see, it's organ failure. It's liver, kidney, brain, coagulation, circulation, and respiration. They are not really have not one opinion how they define it. But remember these different organ failures. And you see here, I tried to make clear what brings them not together. So the Asian one has predominantly hepatic failure variables. The European one combines hepatic and extrahepatic organ failure. And the North American one has predominantly extrahepatic organ failures. They all agree on the brain, because this is the one they have the West Haven criteria as a readout. This is where they all agree. But remember, these organs are in danger, and your patient is in danger. This is a very recent study, barcode here, and you show that this topic that you have chosen for your postgraduate course has global significance. And you see here the prevalence worldwide, and you see it's enormous numbers of people are affected, up to 65% in South Asia, and up to 39% in Europe. And this is the mortality, and you see it's drastic. More than 50% of our patients with liver cirrhosis die of acute and chronic liver failure. You have to recognize it, you have to prevent it. The prevalence of organ failure. Which of these 6 organs comes to a failure first? And it's always the kidney, so paying attention if the creatinine just, rises a little bit. It's always the kidney first, it's coagulation, and it's the liver. So bear in mind, this is already the definition of acute and chronic liver failure. There's also circulation, brain, and respiratory tract. So this is the prevalence of organ failure. And according to the number of organs that have failed, we have different grades of acute and chronic liver failure. You see that here, it's graded. Keep a very close eye on the underlying chronic liver disease. And worldwide, it's alcohol and viral, so the most important. And these are the patients that are going to decompensate and are going into ACLF. Here are the triggering events, and this is very important when you see the patients in your clinic. What triggers acute and chronic liver failure? And it's infection first. This is the patient that classically has an infection or sepsis. And we have the talk of Mark Schurz that really looks into infections in chronic liver patients. So be very, very aware of the fact that infections are one of the most frequent triggers of acute and chronic liver failure. It's also alcohol excess and GI bleeding. That's important and very clinically relevant. So, bacterial translocation, systemic inflammation, this is the pathogenetic basis of acute and chronic liver failure. How does that occur? These are our own data. We have published these data in Gut this year, and we have biopsied patients who we did scope on the preparation for liver transplant, and then we analyzed their colonic biopsies. And what we could show is they do not have the same microbiome. That was not new. We know the microbiome changes in liver cirrhosis. But what is new and what we could show in our patients is that a protective mucus layer is very, very reduced. This enables the bacteria in our gut to engage in direct contact with epithelial cells. And then these bacteria lead to a proteasomal degradation of Acetylene. And the bacteria have like a little scissor, like a bacterial protease, and we are just characterizing that in our laboratory. And this protease, it just cuts the tight junctions of our gut. Imagine what happens. All the bacteria in the gut, they can just go out and really lead to a great bacterial translocation, which is the basis of systemic inflammation. And these are the patients that we have on our intensive care wards, and you know how they present and that they are in septic shock. So this is a 47-year-old female from my intensive care ward, and this is the lab value. And you see she has liver failure, she has coagulation failure, she has kidney failure, and she has a precipitating event. You see that here. It's a pneumonia. It's also it's a herpes simplex virus pneumonia. So this is the classical patient for acute and chronic liver failure. Good news, she survived. She has 3 children, and I'm in a direct contact with her every few weeks. So, but she was on our intensive care ward, and this is what we have to do. It's our job as physicians to find out which patients are in danger, which ones need intensive care. So the diagnosis. I sum this up: cirrhosis plus acute decompensation plus organ failure. I recommend using the Cliff C organ failure score, but you just remember better than mild, better than child. Potential precipitating factors should be investigated. Remember, most important, infections, GI bleeding, and alcohol excess. This is the EASL-Cliff prognostic and diagnostic scores. It's online. You can just find it and then type in all your points that you have received. Management. We are coming now to organ failure, organ support, and to the precipitants and complication. And always keep in mind, acute and chronic liver failure is an absolute dynamic condition, and organ function should be monitored very, very frequently. And to share with you how dynamic it is, this is a 45-year-old male patient who was transported to our intensive care unit by medical transport by air, and he was announced to have severe GI bleeding in need for TIPS at our university hospital. In the air, he suffered from a cardiac arrest and was transferred to our ICU under reanimation conditions. That is the slab. This is the CT scan, and you recognize easily he has a major pulmonary embolism. And this is the GI situation. So he has severe bleeding, GI bleeding from esophageal and gastric fundus varices. So what we did, so you see both clotting and bleeding, same patient, same time, high dynamics. We anticoagulated him, did a TIPS, and he's fine. So very, very, very dynamic. So how do you manage? You have to find out the cause of the liver injury to find out if it can be treated, for example, hepatitis B. Early action is crucial to the patient's survival. We just talked about dynamics. Identification of the precipitating factors. Remember, infections, and you will hear another talk, is crucial. Then treatment of hepatitis B, early referral of the patients to liver transplant centers. Now, I come to the end of my talk in sharing some concepts to treat organ failure. As I said, kidney is the most common organ failure in patients with ACLF. And you should know that there is a new definition of AKI and chronic kidney disease that replaces the nomenclature of hepatorenal syndrome type 1 and type 2. I brought this with me so we don't talk anymore of HRS type 1 and type 2. So, and this is the new definition of acute kidney injury and hepatorenal syndrome, AKI. So new nomenclature, AKI and HRS AKI. And you just have to remember the criteria for HRS AKI that preclude that your AKI has stage 2 or 3. That's important. So what do you do? If you have a patient with kidney failure, you do volume expansion with albumin, and if this does not help, you add vasoconstrictors, but only if the patient meets the AKI HRS criteria. If this doesn't help at all, you have to start renal replacement therapy. Coagulation. Hypercoagulation, as in our patient, is an independent marker of poor prognosis. And hypocoagulation is usually found in patients with CS. In the absence of contraindications, because you have hyper and hypocoagulation, you should really give your patients low molecular weight heparin to prevent venous thrombosis and emboli. So that is important. Circulation. A higher mean arterial blood pressure may decrease the risk of ACLF, and norepinephrine is the vasopressor of choice in your patients. A last word to the brain. It's very important to distinguish hepatic encephalopathy, sepsis, and a delirium, and a dementia, or other psychiatric disorders. And this is the key to the treatment of these patients. And always remember, hepatic encephalopathy and sepsis can occur together. For the medications, use non-selective beta blockers. We have discussed that because they decrease bacterial translocation, they prevent ascites formation, and they reduce portal hypertension. Remember rifaximin, which may prevent complications of cirrhosis other than hepatic encephalopathy. Last word to artificial liver support systems. There is no clear clinical benefit. Plasma exchange has, however, been shown to improve survival in patients with acute liver failure. We are using it also in patients with acute and chronic liver failure on my ICU, and we have made very, very good experiences. Thank you for your attention. If you like to have the whole talk, this is the barcode with the contact data. Thanks a lot. I'll be happy to take your questions.
For this elegant lecture. You mentioned the role of non-selective beta blocker in prevention of decompensation. So for how long, and what if the patient developed ascites? There is some concern about refractory ascites.
Right. So this is a very important question. It relates to the long-standing debate of non-selective beta blockers in these patients. And I have really had a very close look and also changed my personal mind in the use of these beta blockers. We know that there is large data out that says beta blockers can be deleterious for your patients, and your patients don't tolerate them. And you know, I changed my mind really, because it's true that beta blockers lower blood pressure, but all the data that we have right now, and this is in view, this is why I showed this new paradigm. They say beta blockers can do much more than just reduce portal hypertension. They reduce the bacterial translocation, which is the basis of systemic inflammation. So to cut this short, beta blocker use is absolutely advocated. You can use propranolol or carvedilol. And when do you have to stop? This is your question. And we know right now that even in a patient, you know, that has low blood pressure, we do not only need to stop if the mean arterial pressure drops below 65 millimeter mercury. And no, we do not have any rules anymore about pulse rates or anything. So we are much more confident that beta blockers are a pharmacologic principle that is the right thing to do. And I completely changed my mind, because we tend to stop too early on these beta blockers. And I did that too many years. And then I realized that this is the key to keep your patients compensated. And this is why I'm to answer that so really comprehensively. So please take beta blockers. They help you to keep the patients in a compensated status. You have to really dose them up. And in carvedilol, your end dose is 25 milligrams. You start with 6.25 milligrams. In propranolol, the end dose is 80 milligrams, and if there's no ascites, it's 320 milligrams. So these doses, we do not normally apply them, but the patient at the end tolerates them. And you have to, that's also your question, when do you have to stop? Absolutely, if the mean blood pressure, and that's your only readout, mean arterial blood pressure below 65. And of course, if a patient goes into sepsis, that's clear. And then you have to reduce. But if you have saved him or her, you put him on beta blockers again. This is a really, really, you know, a statement pro-beta blocker. And also, I tell you, I have changed my clinical practice based on these studies.
Hello, Dr. Gasser. Thank you very much, Prof. Martina. I have a very short question. I'm here. Yeah. You mentioned liver stiffness measurement. If it is below 20 platelets, more than 150, yeah, it's unlikely to have varices, and we can do annual elastography. Okay?
Yes.
And then if from 20 to 25 and platelets is less than 150,
yeah,
we can go directly to carvedilol without endoscopy. Right. No need for endoscopy to confirm varices.
Yes, I understand the question, and my own practice was also to do the gastroscopy. This is new data from the American College of Gastroenterology. And I confess, we do liver stiffness and platelets and the gastroscopy to answer your question. So it's, but the new thing is really to take a close look and to use liver stiffness as a predictor, as a risk predictor. And there's a study out that uses MELD plus liver stiffness, so also to replace these risk scores. But I agree with you, you could also scope the patients, but not only. And it's easier for the patients if you repeat the liver stiffness. That's the advantage. You can repeat the liver stiffness plus thrombocyte count easily every 3 months, but patients don't like to be scoped every 3 months. But a yearly gastroscopy is fine in my eyes.
Thank you.
Thank you very much. And thank you very much for having me here. I enjoyed this conference and the wonderful topics. Thanks a lot.
Next speaker, Professor Mark Sarkis from Imperial College of London, UK, and his talk about susceptibility to infection in patients with liver failure.
Great. Well, thanks again to the organisers for inviting me to give a talk. And this is really, I think, an important topic, which is regarding infection. And as we just highlighted, one of the commonest precipitants of acute decompensation in ACLF. So I want to kick off this talk by giving a little patient case history of a 58-year-old male presenting, very similar to a patient I saw on the ward round this morning, presenting with jaundice, abdominal swelling, a quite considerable alcohol history on a background of diabetes and hypertension, for which he's taking metformin and amlodipine. He's a little hypotensive, no temperature, and he's a bit overweight. And on examination, he's got some features of chronic liver disease as detailed here. So here are some blood tests on admission. The patient's a little anemic, lowish platelets, prolonged prothrombin time, high white cell count. Bilirubin pretty high, albumin very low, and his transaminases are just moderately raised, as is his alkaline phosphatase. Nothing much going on in the rest of his investigation. At this point, his renal function is excellent. His ultrasound shows it confirms the ascites, as you can see here. The rest of his hepatitis screen is all negative. So by these clinical criteria, this is a patient with alcoholic hepatitis. He fits all of the criteria set out here. And then if we use conventional scoring systems to classify this in terms of severity, so his Madry's discriminant function 83, MELD of 27, and the Glasgow alcoholic hepatitis score of 9. So he's severe on any of these measures. So alcoholic hepatitis is a form of liver failure. So it's a clinical syndrome, obviously happening in patients who are heavy alcohol users with a recent onset of jaundice, often accompanied, even if the patient isn't cirrhotic, by features of liver failure. The biopsy will show typical steatohepatitis features, and maybe 80% of these patients probably have background cirrhosis, but not by any means all of them. And this is one of, if you like, 3 different forms of liver failure. And this paper, this is going back now for 30 years. Nancy Rolando and Roger Williams published this in terms of the incidence of bacteremia, respiratory, urinary, or cannular infection amongst patients with liver failure of any type. The take-home message was really very simple. Infection is really common in these patients. Infection has an impact on the prognosis, and as we'll see in a moment, some of the features, the normal features of sepsis, are frequently missing. And just to quantify this, so acute liver failure, acute decompensation, including ACLF and alcoholic hepatitis, are all immunodeficiency states with increased susceptibility. So acute liver failure after admission to hospital, 35 to 40% of patients will develop infection. In acute decompensation, sometimes of course infection is the cause of the decompensation, as we've just been hearing, but in those who come in without infection, 15 to up to 50% in some reports will develop an incident infection or will develop one during the hospital stay. In alcoholic hepatitis, it's probably best documented. 25% have infection at presentation, 30% have incident infections after presentation. Now, the definitions of infection can cause some clinical problems. So these are North American chronic liver disease group criteria, and they require objective evidence of infection. For instance, positive blood cultures, positive counts on ascites, evidence of consolidation on chest x-rays, and such like. And the reason that this causes us a problem is if you're reporting on infection and you require these, it's slightly different from how we manage the patients in real life. And let me just illustrate by going back to this clinical case. So his baseline, Mr. AH, his baseline infection screen was negative. He has alcoholic hepatitis. The team decided to start corticosteroids, prednisolone, 40 milligrams daily. By day 7, his bilirubin really hadn't gone in the right direction. His clotting was still abnormal. His creatinine was still okay, but he has an adverse Lille score, so it's over 0.45. So we know that in that case that steroids have no impact at all. In fact, adverse effects potentially. So the steroids were discontinued. So on day 9, suddenly things start to change. The patient is anorexic, lost his appetite, not getting out of bed. His pulse has gone up a bit, his blood pressure has gone down a bit, but he doesn't have a temperature. White count has gone up, his CRP is marginally higher, and his creatinine is marginally higher. So the clinical team send off an infection screen. And the key question that we need to think is, well, would you treat with antibiotics prior to getting an infection screen back, but prior to getting your blood cultures or objective evidence? And so the team in this case waited, and they day 10 they get actually the white cell count in his ascites, as you can see, is raised over 250, and so he was 24 hours after his minor deterioration started on piperacillin tazobactam. In the real world, we don't always get pyrexia, and in this group of patients we don't always get a rise in the white blood cell count or the CRP. What's more common is a rise in creatinine as renal function starts to deteriorate. We get deterioration in vital signs and a deterioration in performance status, by which I mean the WHO performance status, which is a little bit like, when you see your patient, just seeing that they are really just not themselves. That in itself should be enough to initiate antibiotics without waiting for objective criteria. So what is the significance of infection in alcoholic hepatitis is well detailed, but the significance of infection in other forms of liver failure is similar to this. So baseline infection, i.e. the infection that's there at the time that patients are admitted, appears to make no difference to the mortality from this condition. So patients are assessed initially, given treatment for their infection. In general, they're not treated with steroids until the infection in alcoholic hepatitis, until the infection is fully under control. But that's different from incident infection. So after admission to hospital, if then the patient develops an infection in alcoholic hepatitis, acute liver failure, etc., then the mortality increases significantly. And often these infections, because they're in hospital, they're nosocomial infections, often multi-drug resistant, and may be difficult to treat. So how do steroids impact the risk of infection? So in alcoholic hepatitis, the evidence is somewhat controversial, but nevertheless, steroids are still widely used. And this is what we found. This is data out of our Stopper trial. It was published a few years ago now. And you can see here we can measure the incidence of infection in two different ways. All reported infections, you can see here the blue lines, patients treated with prednisolone compared to the placebo arm. They had increased rates of infection all the way up to 90 days after admission. But if you specifically looked at those infections that are considered to be severe, i.e. they were potentially life-threatening, then you can see that the incidence of infection in the prednisolone-treated group is much, much higher than those who didn't. And this is probably why steroids are not such a good idea in this group of patients. And the type of infections that we get, probably most common is the respiratory infections, followed by spontaneous bacterial peritonitis and urinary infections, and then a few unknowns. But I draw your attention to the figures at the bottom here. Only 40 to 50% of infections result in positive cultures. And that's important, because if you're waiting for culture data, then you'll miss the opportunity to treat before the patient progresses to acute or chronic liver disease. I guess one of the important things is, can you actually predict who's going to get an infection? And in alcoholic hepatitis and in other conditions, there are a number of variables we can look at. The performance status, interestingly, in multivariate analysis, along with the white blood cell count and the renal function are the things that seem to be most important. And alongside this, the severity of the liver disease, whether you measure it by discriminant function, MELD, GAS, LEAL, whichever, these, the severity of the underlying liver disease is closely correlated with the risk of infection. So is there any other tests that we can use to help predict? Well, we found you can measure bacterial 16S ribosomal DNA in whole blood from patients with acute liver failure or patients with alcoholic hepatitis. You can quantitate that using this real-time PCR assay. And what we found, interestingly, is that patients who had a relatively high bacterial DNA, all of them seem to have more bacterial DNA than a healthy individual or someone with compensated cirrhosis. But if they did have a high level and then they went on to a treatment with prednisolone, i.e. they were immunosuppressed, then that resulted in a severe infection within 7 days. So 16S might be a useful biomarker in the future. Of course, it begs the question of why are these patients with liver failure susceptible to infection? What's gone wrong, particularly with their innate immune system? And there's lots of avenues of research in immunology here, but I just want to highlight two that I think are really important. The first is looking at circulating monocytes and circulating neutrophils. So normally these cells would ingest circulating bacteria. They would, the bacteria would find their way into these endolysosomal compartments, which would then generate through an oxidative burst, these reactive oxygen species, which would then kill the bacteria. So you've cleared the risk. So we can measure the monocyte oxidative burst. And if you look at a group of patients with alcoholic hepatitis, in this case, and you dichotomize them into low oxidative burst and high around the 50th centile of the monocyte oxidative burst function, you can see that those who have the lowest 50%, the lowest levels of oxidative burst are 12 times more likely to get subsequent infection than those whose oxidative burst levels are relatively normal. So clearly this is important in the progress of the infection. One interesting finding here is if you take monocytes that have ingested bacteria and then you lyse them, then you can recover and count the number of bacteria that they've ingested and that are still alive. So if you do this from patient monocytes with alcoholic hepatitis or with liver failure, you recover lots and lots of bacteria because they failed to kill them. If you incubate their monocytes with N-acetylcysteine as a basically restoring their oxidative or protection against oxidative damage, then it turns out that more of the bacteria have been killed, so you recover less bacteria. And the reason this is interesting is because of this trial using N-acetylcysteine along with prednisolone in patients with alcoholic hepatitis. And you can see here that the rates of infection were halved by the use of N-acetylcysteine. And we know that N-acetylcysteine helps in some patients with acute liver failure as well. And the second mechanism I just want to highlight is in a model of acute liver failure. So a mouse here given paracetamol or acetaminophen and then challenged with E. coli that have been fluorescently labeled, and then you can look in the liver in real time in a living animal and look at how well the Kupffer cells and monocytes in the liver ingest the bacteria. And after acute liver failure, there is a failure to ingest the bacteria. So if those bacteria are not cleared in the liver, so this is the capture here in this graph on the left. If you reduce the amount of capture then and bacterial uptake, then the amount of bacteria in the circulation increases. And if you then look at the respiratory or renal organs, you'll find more bacteria that have translocated to those organs, potentially causing sepsis. So two mechanisms then at an immunological level, one being failure of killing of bacteria by oxidative burst, and the other being failure to clear the bacteria from the blood after translocation. So how do we, coming back to clinical lessons then, how do we prevent infection? Well, I think the use of corticosteroids in conditions like alcoholic hepatitis have to be really judicious. And we now use the neutrophil to lymphocyte ratio, published by ourselves and others, to select suitable patients. It may well be that N-acetylcysteine is helpful, and there are ongoing studies to confirm that. Measurement of 16S ribosomal DNA may indeed help, but that assay is not yet widely available. There was a recent trial in alcoholic hepatitis using prophylactic antibiotics, but this showed no benefit. And the mechanism I just told you about in terms of ingestion of bacteria by monocytes and other phagocytes, actually it turns out that treating with anti-PD-1 in the mouse model or in human cells seems to restore some of the monocyte function. And just finally, I just want to draw your attention to nutrition. This was a trial by Christophe Marino's group a little while ago, looking at intensive nutrition versus conventional. And what I want to draw your attention to is the fact that in patients who were able to ingest more than 21.5 kilocalories per kilogram per day, both survival was improved, but also they reduced infections significantly. So getting our patients to eat does seem to be rather important. So coming to the end of my talk then, my conclusions are that infections are common in alcoholic hepatitis and in other forms of liver failure and therefore have a negative impact on prognosis. We need more data on the 16S as a biomarker to pick up these infections at a preclinical stage. And loss of Kupffer cells, macrophage, and monocyte functions is probably the background cause of much of this susceptibility to infection. And when it comes to the clinic, what's absolutely critical is our clinical acumen, our diligence to see small deteriorations in the patients and act on it is really rather crucial. So going back to my patient, what happened? Well, sadly, within 24 hours of initiation of antibiotics, the patient developed systemic inflammatory syndrome and progressed to multi-organ failure, so ACLF4, and sadly died at day 13. And there's just a suspicion that if the antibiotics had been started 24 hours earlier, when he first started to deteriorate, then the patient's outcome might have been different. I'll just finish with some accreditations, acknowledgements of people who have worked on some of the immunology and some of the clinical studies with me, and I thank you for your attention.
Thank you so much for your presentation. Now we are asking the floor. Do you have any question?
Thank you for that informative lecture. You mentioned the role of N-acetylcysteine in prevention of infection. So do you think that it could be prescribed for all patients with alcoholic hepatitis for prevention of infection, or even for patients with cirrhosis?
Yeah, no, I mean, there's a good question, and clearly the amount of clinical trial data in this area is not brilliant. There is that one very good trial by Ngo and Cat, but outside of that, we lack data. On the other hand, N-acetylcysteine we know is incredibly safe with minimal side effects. We give it frequently for paracetamol, acetaminophen overdose. And the only patients with whom I would be maybe a little bit cautious is where they're volume overloaded, because normally we give N-acetylcysteine in fairly large volumes. But I think it's actually probably quite a safe thing to administer.
Okay, thank you. Any other question? Yes. Professor Terry.
Thank you, Professor Thurs, for your talk. And please, how about the markers, the known markers for diagnosis of infections, especially in cases of chronic liver failure and acute on top of chronic?
So if you're talking about normal clinical markers like white cell count, temperature, and CRP, so
CRP, procalcitonin, and the scores with there are new scores for diagnosing infections, especially in acute on top of chronic.
Yeah, I mean, particularly, so the conventional tools don't work very well. Okay. The procalcitonin, there is one study that suggests that this may well be a good indicator, perhaps being positive even before you get clinically overt infection. But in our hands, the procalcitonin has not been very helpful. And there are, of course, new assays for fungal infections, and as you're aware, all of these patients are, after 10 days in hospital, frequently fungal infection is a problem in all three categories of acute liver failure. And sadly, the beta-glycan type assays, they're not brilliant. They often, if they're positive, they're positive. That side of it's very good, but their sensitivity for fungal infection is relatively poor.
Okay, any other question?
Thank you, Professor.
Thank you, Professor Thurs, and we hope to see you in Cairo next year, inshallah. Now we'll move to Professor Iman Abdusamia. He will share with us her expert opinion about application of artificial intelligence in liver disease.
Applications of artificial intelligence in liver diseases. Artificial intelligence is a branch of computer science that attempts to mimic human intelligence, such as learning and problem-solving skills. The term is not new. First described in 1937 as universal computing machine by Alan Turing, the term artificial intelligence originally coined in 1955 by John and McCarthy. Common terminologies. Machine learning algorithms, they regression models and support vector machines are used to predict disease progression, presence of complications, and mortality. Deep learning algorithms enable rapid, automated interpretation of radiologic and pathologic images. Artificial neural network. Loosely modeled neurons of the brain with multiple layers of connected mathematical functions. Convolutional neural network is image-based machine learning tool inspired by visual cortex of human brain. Natural language processing extract clinically meaningful concepts from vast quantities of unstructured data in electronic health records. We can have diagnostic models and therapeutic models. Examples for applications in hepatology. Hepatology started studies later after endoscopy. More studies are present in the last 2 decades. Detection of liver fibrosis and chronic liver disease. AST, ALT platelet count were used by Wei et al. To construct machine learning algorithms to predict fibrosis in patients with chronic hepatitis B virus infection, and the model was superior to FIV4. Cirrhosis complications. Don et al. Developed EV endoscore, used random forest algorithm. It depends on INR, AST, platelet count, blood urea nitrogen, hemoglobin, and ascites to predict the presence of esophageal varices, and the varices need treatment. At cutoff level, below 3.9 can spare 30 to 40% of patients from undergoing upper endoscopy, while missing only about 1 to 0.1% up to 2.8% of patients with varices needing treatment. Natural language processing was used to analyze electronic messages from patients with cirrhosis, suggested that longer sentences with shorter words predicted presence of hepatic encephalopathy. Prognostic artificial neural network models for predicting 28 and 90-day mortality rates of HBV-related acute and chronic liver failure was developed. The model predictive accuracy was significantly higher than that of MELD. In setting of liver transplantation, machine learning algorithms have been developed to predict pre-transplant survival in patients with cirrhosis, to assess the best donor to recipient match during allocation processes, and to foresee post-operative complications and outcome. As regards NAFLD and NASH, NAFLD Ridge score, one of the important scores dependent on machine learning-based prediction model, uses HDL cholesterol, triglyceride, hemoglobin A1C, white blood count, and the presence of hypertension to predict NAFLD. With prediction accuracy 87%, and sensitivity more than 92%, and specificity 90%. Supervised machine learning algorithms trained on longitudinal lab-based parameters within large ultrasound-based electronic health records for identification of NASH. This figure shows how different types of input data, such as through electronic health records, enter traditional machine learning methods, for example, logistic regression and random forest, to have prediction score. And here, medical images such as biopsy and CT images and MR images can enter into convolution and pooling in convolutional neural network to have prediction score. Diagnosis and management of hepatocellular carcinoma. Deep learning-based system for 3-dimensional segmentation of the liver and HSC detection yielded prediction accuracy about 86.9%. Logistic regression and random forest models to MRI applied also to predict transarterial chemoembolization response with an overall accuracy 78%. Predictive modeling using omic data. Omics data, recently advanced molecular analysis with multi-omics studies can be used to develop machine learning algorithms with high predictive accuracy and help identify novel biomarkers. Support vector machine algorithm was used based on lipidomic, glycomic, and hormonal analysis differentiated among healthy, NAFLD, and NASH subjects with 90% accuracy. Using AI, depending on genome sequencing of patients with HCV, identified that interleukin 28B single nucleotide polymorphism, a predictor of advanced fibrosis, performed better than ABRI and FIB4. In drug-induced liver injury, machine learning algorithms dependent on advanced molecular data can be applied to drug development to predict hepatotoxicity. Models of different AI developed using molecular fingerprints from 1,024 chemical compounds predicted daily with high accuracy. As regards biliary diseases, current AI research focus on oncological applications, mainly cholangiocarcinoma. Radiomic analysis is the most common method used for lesion characterization, prediction of lymph node mets, prognosis and treatment response evaluation. As regards pathology, it is well known that the gold standard of diagnosis in many liver diseases is histopathological analysis. Through digitized pathology images, we can allow application of different machine learning algorithms. Support vector machines was used to construct automated, stain-free system that assess fibrosis in patients with HBV infection by quantifying amount of fibrillar collagen on microscopy. Studies used also algorithm and developed automated software quantify steatosis, inflammation, ballooning, and fibrosis in patients with NAFLD with high inter-observer and intra-observer agreement. And this figure shows how AI can improve accuracy and concordance in histological assessment of NAFLD severity. This is clinical application of artificial intelligence that we mentioned. The future. In the future, AI could be used to develop highly accurate models for predicting disease progression and complications, enable automatic identification of disease on radiologic and histopathologic studies. But area of unmet need remain, including alcohol-associated liver disease and genetic autoimmune liver diseases. Moreover, inherent bias such as racial discrimination can be included in AI algorithms to determine risk of fibrosis related to viral hepatitis. And it is important to consider these factors in developing AI models and validate the models in a range of populations. In conclusion, AI research is rapidly progressing, and it would be vital for hepatologists to understand and incorporate AI models as helpful tools that can assist clinical decision-making and lead to improved care for patients with liver disease. Thank you.
With this fascinating look on the future, do you think that we are capable now with our faculties of artificial intelligence to employ it currently? Or it's only a matter we import from outside?
AI needs medical personnel and advanced software that have a high cost. But in the Faculty of Artificial Intelligence, that we will have a protocol with Professor Dr. Gasser and our colleagues with this faculty to have
we are starting
and obtain,
already on
yes,
okay,
in GI. And in different parts of hepatology, such as NASH, NAFLD, and fibrosis.
Okay. With this optimism, we have to end the session. For no more optimism we can end with.
Thank you.
So, thank you, and we are moving to the next session.
We invite the chairpersons of the next session, Professor Ahmed Matkour, Professor Ali Nada, Professor Magdi Dahshan, Professor Muhammad Magdi, and Professor Anwar Abdelalim. He's online. Online? Ah, he's online.
فين ده؟ ما هنا ليه؟
Thanks for organizer for this kind organization, and now we hope to open the new session about advances in endoscopy, and we will start with Dr. Muhammad Osman, Baylor College Medicine, USA, and he will talk about tips and tricks in cholangioscopy, a case-based approach.
All right, so I think I will start first. So this is more like a case-based approach of cholangioscopy. So basically, I will discuss some cases, and I will let you know what I think about the management. Usually, when we do these cases, we have a discussion, but since it is online, I'm just gonna skip the discussion, go right away to the videos. So that's one of my patients, 48 years old patient, presented to an outside hospital for cholangitis from impacted CBD stone. So first presentation is cholangitis. It has large stone. The endoscopist couldn't remove the stone during the emergent ERCP with a بيحصل كتير. When you go in, you cannot remove the stone because it's more like impacted, or there's a lot of burden of stone. So what he decided to place plastic stent, and he decided to schedule repeat ERCP in 2 weeks. So now we have a stone, stent draining the cholangitis, and later on, 1 week later, the patient came with another episode of cholangitis. So what happened? What happened is that the stent that the doctor put in the bile duct to treat the cholangitis got absorbed up in the duct. So the patient now have impacted stone and a plastic stent. Later on, this is what happened. He could not remove the stent. So basically he went in, the stent is inside the duct, trying to remove the stent, he couldn't remove it, couldn't remove the stone either. Patient have now second episode of cholangitis. The endoscopist is very stressed, doesn't know what to do. What did he do? He placed a metal stent. So now he put a metal stent, brought the patient back in 3 weeks for stone removal. The metal stent migrated into the bile duct. At that point, he called me and say, I'm in a trouble now. I have a plastic stent, metal stent, and a stone in the bile duct. I'm going to send the patient to you. So the patient was transferred to Baylor College of Medicine. Now, you can see here, that's the beginning, the x-ray. If I stop for a second, that is a plastic stent migrated up in the duct. That's a metal stent. So both of them is migrated up in the duct, and there is a stone around it. So what did I do? In this situation, you have many options to remove the stone. Some people will say, you can put a balloon and a wire and try to go in. Other people would say, maybe use biopsy forceps or use basket under fluoro. But since I know that the physician tried all this stuff and it didn't work, I tried to do something different. What we did here, we used cholangioscopy, and what we are seeing right now, that's not a normal bile duct. This actually, the stent is a fully covered stent, and these are the mesh of the stent. And right now, I'm inside the stent. So the stent is a little bit high up, so I'm using a biopsy forceps and trying to move that stent down. So I'm pulling the stent with the scope and pulling it all the way till it got to the opening of the bile duct. We know that that forceps called spy-bud forceps is very small. So it got the stent all the way to the opening of the bile duct. And now I'm using a raptor, which is a combination of grasper and rat tooth, and I'm pulling it outside the duct. So you can see here that the cholangioscopy helped us to get the stent all the way down and to pull it outside the duct. Now it is too close to the opening. I was able to use the grasper. Still, now we have the plastic stent and the stone, and we have to manage them. So we got the big stent, which is a metal stent. And you can see here, it looks like there's a big stone, and that is the reason that the other stent or all the stent keep migrating. And it's because also patient anatomy. So I decided to fracture the stone first from around the stent and get it outside. Then removal of the stent will be easy. So remember, if you ever have a migrated plastic stent and it's much harder to get it out with balloon, then there must be a reason for that. Either you have a diverticulum or maybe you have a larger stone inside. And in this situation, you should just fracture the stone. So what we're showing right now is laser lithotripsy of a stone in the bile duct. And you can see here that my technique is to focus on the stone. You don't want to be touching the stone directly. It's almost like when you do APC, you want to have a small space. You want to start focusing in the middle. Some people, I see them going up, down, putting laser here and there. No, focus in one area. As you can see here, we're focusing in the middle using water irrigation. And you keep working in the middle to defracture the stone completely. Once the stone is fractured completely, then it will be much easier to put your, after that, a raptor and get it outside, or a balloon. So you can see here that we're continuing to fracture the stone. Most of the time, once I embark in a stone fracture, I try to finish it in the same session. You can approach that if you really focus on fracturing the stone from the middle, as you can see, like tunnel through the stone in the core of the stone, and that's what allow you to open it completely. You see a lot of inflammation in the duct as expected. When you have stones, the duct will be inflamed. It's not cancer. I'm going to show other cases how the cancer looks like. Then now, easily with the balloon, we are getting the stone fragment, and also we'll be able to get the stent from the duct after that. So once we get the stone, it will become much easier to get the stent. You can see here this patient also have preambulary diverticulum, which made all this stuff harder in this situation. So that's the first case about treatment of migrating metal stent. Now I'm going all the way up above the plastic stent. The duct is clear. It should be coming nicely when we are sweeping the duct. And I know the view is not that great, but in that sweep, that's when we got the stent out. And this was a good ending story for that case. Our take-home point here, that cholangioscopy with biopsy forceps can successfully detach the migrated mineral stent from upper CBD and facilitate complete removal. All right, we'll move on to the next case. It's a 78-year-old patient who had Wobble surgery for IPMN involving the pancreas and bile duct. So he had a rare disease. We know that IPMN, main duct, intrapapillary mucinous neoplasm, it affects the pancreas in the main duct. But sometimes it can also affect the bile duct, as in this patient. And he had Wobble. He did so well for 2 years. Then he presented later with elevated alkaline phosphatase and dilated intrahepatic duct. Surgeon called me, "You do think what's going on? Can you please take a look?" So right now we want in with ERCP. Of course, post-Wobble, you will have to use something like pediatric colonoscope to reach to the anastomosis. You can see here, that's the opening, a lot of mucin coming out. When you see the mucin, it is very concerning. And then I was able to put a balloon inside the duct. We're seeing normal ducts here. As you know, in the Wobble anatomy, the right system and left system are next to each other. They're not attached together, so they have separate opening because you have what we call hepatocogenostomy. So you will have to examine both systems separately. But the question is, how far is the disease inside the liver. So we're able to place conjugoscopy and know the extent of the disease. I'll show you right now. Now we are putting the cholangioscope. That is a normal epithelium, and immediately you can see the transition to abnormal IPMN of the bile duct. This is a rare finding. It's a papillary projections, and you can see how they look like under cholangioscopy. Now we were able to determine that actually the disease is really involving both system, and it's going so deep in the liver. Unfortunately, this patient was not candidate for further surgery, and he was not a candidate for another like further treatment. He elected not to have any treatment. So I think we placed stents in this situation. It's a sad story, but at least was using a spyglass, we're able to see, or cholangioscopy, we're able to see the extent of the disease and how far it is, and know that it is really extensive. We're also able to take biopsy, as you can see here. So the teaching point of that case is that it's another important function for cholangioscopic examination of the bile duct. It allows us to have an accurate localization of the extent of the disease and tailor further treatment. So quickly we'll go to case number 3. And case number 3 is a 37-year-old patient who had no prior medical history, who came to the ER with severe abdominal pain. CT scan showed dilated pancreatic duct, possible 1 centimeter mass obstructing the duct at the level of the body of the pancreas. So 37 years old, unlikely it is cancer, but who knows? And it's 1 centimeter mass. And then we did cholangioscopy to see how this mass in the duct. Actually, it's not a mass. It is, as you can see here, a stone. So this is a calcific stone of the bile of the pancreatic duct. So there's difference of this type of stone and the stone we see in the bile duct. In the bile duct, they are cholesterol stone. They are softer. This one here is much harder. I think we're doing here EHL of that stone. And as you can see here, I'm using higher energy. So when you do lithotripsy for pancreatic duct stones, you have to use higher energy. So in your setting, you have to set the energy for higher energy. Cannot start with the low possible one as we do in the bile duct. These stones are calcific stone. They're almost like a rock. And we can know that if we cannot do lithotripsy, we might need to do electric shockwave lithotripsy as well, especially for stones at the beginning of the duct. But as you can see here, for these stones, it works very well for the mid-CBD stone, mid-pancreatic duct stone. We can use cholangioscopy. Something else about the difference between stones in the pancreatic duct and bile duct. And pancreatic duct stone sometimes is very attached to the wall here. So sometimes we have to gently clear it from the wall because the calcification starts at the wall and then go to the middle. You can see here I'm using the same technique of tunneling in the middle of the stone, but knowing that at the end this stone is attached at the wall here, I will have also to fracture that part closer to the wall, but I will have to make sure that you don't affect the pancreatic duct and apply a lot of energy there, otherwise the patient will get pancreatitis. But you can see that the stone almost becoming part of the pancreatic duct wall, and it's so attached that you cannot just separate it, you have to break it. And this, when you do the lithotripsy for pancreatic duct stone, you have to be comfortable working very close to the mucosa like that in order to get the stone. So first you start in the middle, fracture the stone, and then you try to clear the wall completely. We also take biopsies sometimes because, you know, when you have a lot of inflammation, this could lead to dysplasia. So some of these patients have a higher risk of getting cancer because of obstruction for a long time. So once we clean the stone, sometimes I take biopsies in that session or later on. We can see here that we nicely open the duct in this situation. So it's the teaching point in this case that ERCP cholangioscopy can assess the evaluation of pancreatic duct lesions, and pancreatic duct stone can be successfully managed with ERCP cholangioscopy and later lithotripsy. All right, case 4. And I have 5 cases. I'm not going to keep you long. So pancreatic duct stone. Here we have a patient. Case 4 is 26 after pancreatic duct stone. We have another case of 60 years old. We have jaundice and CBD stricture. So we have a CBD stricture the ERCP showed met CVD structure, brushing was obtained, it did show a typical cell. Patient has plastic stent, referred to me for ERCP with a spyglass. You can see here. That's what we're seeing in conjugoscopy. A lot of blood vessel, very thickened mucosa. That's almost always malignant structure. So when you see that, you know that this is malignant structure. So when you take this biopsies, we call them spy bite biopsies, you have to do one on top of one. If you take only one, move to another area, take another one, they will be very superficial and they will not be helpful. So you will need to take one on top of one, on top of one, on top of one. And that's what I do. If you notice here, we're focusing in one area and just doing biopsy on top of biopsy. And that's helped to do the examination. I'm also irrigating the duct. And while I'm irrigating the duct, I'm collecting that fluid and send it for cytology. It's very cheap. It doesn't cost much to irrigate. When you are irrigating and taking biopsy to take the fluid, we call it aspiration fluid cytology. So you can see here that cholangioscopy is important for evaluating indeterminate biliary structure. I just want to quickly share this case with you. This is a study we did that was recently published about adding aspiration fluid cytology to the biopsies we're getting by cholangioscopy and brush cytology. You can see here in our series, sensitivity for cholangioscopy 66%, and cytology is not that better, but you add to them the aspiration fluid cytology, it jumped to 80%, specificity is 100%. So it's a very cheap and something you can do. I don't think it will cost you much to just collect the water, suction it from the cholangioscopy and send it. And you'll be surprised that in some cases, because you're doing biopsies, you can detach this abnormal cells. Last case, 85 years old patient with cholangiocarcinoma of the bile duct. He keep coming for stent exchange because he is refusing any chemoradiation treatment. He's also high risk for surgery. So we can do radiofrequency ablation in this situation, and the radiofrequency ablation can really decrease the frequency of stent exchange. So you can see here how old the stent is. We're removing the stent. We would use cholangioscopy to know how far to do the radiofrequency ablation. So yes, in cholangiogram now, because the patient has a metal stent, everything will look dilated. You wouldn't know the extent of the structure anymore. You actually have to take a look. You have to go in. You have to see what is the length of the cholangiocarcinoma. So that's how cholangioscopy is very important. It gives you this tailored treatment. So as we can see right now here, we are going all the way up, and you can see the bifurcation is here. The cholangiocarcinoma is stopping just above the bifurcation. So as a result of that, I know that when I use the catheter for ablation, this catheter is a 3 centimeter in length. I estimated that this length of the area is 6 centimeter. So I knew right now that I have to start just below the bifurcation and apply ablation, and then go another one, apply another ablation, as you can see here. So that's like the RFA ablation catheter, and we're putting it at the bifurcation and going down, and we'll continue the treatment. And now we are going to put the cholangioscopy again, and we'll see the treatment effect. What do you expect in this situation? Since you applied ablation, you'll find that the tissue now is very white, the tissue now is very burnt, and you can note that we did a good job with the ablation here. So that's a confirmation of ablation. You can see the bile duct is ablated very well. And now we can put new stent, and that stent might last longer. So this also another indication is to do ablation and to use the cholangioscopy before and after. And now we're placing the new fully covered metal stent. So what's the teaching point here? That ERCP with cholangioscopy can assess the extent of CVD involvement with cholangiocarcinoma directing RFA therapy, and the ERCP with cholangioscopy can also assess the effectiveness of the ablation of the common bile duct and ensure complete ablation of the entire involved segment. Thank you so much.
شكرا دكتور محمد. أنا مجدي الدهشان من الأزهر. Thank you for your interesting cases. Professor Muhammad Al-Hayawan of the eminent gastroenterology in USCA. He is a professor of medicine and a professor of GIT and hepatology in Imperial College, and now he is the head of gastroenterology unit. شكرا دكتور محمد. الحقيقة المحاضرة very interesting، واحنا بنعتبر ان عندنا 2 محمد صلاح، واحد في ليفربول وواحد في امريكا.
الله يخليك يا فندم، ما تحرمش منك.
شكرا يا فندم، ونشارك بقى في مؤتمر الازهر ان شاء الله سيف ذا ديت 23/8 ان شاء الله، كما تعودنا كده سنين طويله معنا ان شاء الله. شكرا يا بيه.
ان شاء الله. شكرا يا فندم.
We will proceed to the next talk. The title is Third Space on this Now versus Future by Dr. Mohan Ramchandani, Asian Institute of Gastroenterology, India. Professor Dr. Mohan Ramchandani is a director of intervention endoscopy at AIG hospitals, Hyderabad. He is an expert in advanced procedure like third space endoscopy, spyglass, cholangioscopy, ERCP, endoscopic ultrasound. He will talk this lecture.
Can you hear me? At the outset, I thank the organizing committee for giving me this wonderful opportunity. I hope I am audible over there. Can you hear me, please?
Hi, Dr. Mohan, how are you? This is Ahmed Madkour. Yes, we can hear you.
Thank you so much. So at the outset, I thank the organizing committee for giving me this wonderful opportunity. And I'll be speaking about third space endoscopy now. And I bring greetings from Hyderabad. This is Charminar, and on right side, I have the pictures of pyramid, which I took a few months back when I was in Egypt, and warm greetings from India. So let us talk about third space endoscopy. Now, as we all know, as we started the endoscopy, it was basically a luminal endoscopy, and that is why it is conventionally known as first space. Then came the note when we deliberately punctured the stomach or any other hollow organ, and then went inside the peritoneum and did all the procedures, including cholecystectomy or appendicectomy, and that was known as second space. But unfortunately, because of the tough competition from laparoscopy and non-availability of the dedicated accessories, the notes did not pick up. But it gives birth to a new branch that is known as third space endoscopy. It is nothing but working under the mucosa in the submucosal space, and the principle of mucosal flap wall was brought in when we started dissecting the gut wall, and gut wall was not considered as a single wall, but it is a layered structure when we create a mucosal hole and then create a tunnel between mucosa and the muscularis propria, that is known as submucosal tunnel. And then subsequently we can go into the muscle layer and treat the muscular disorder, or even go inside the peritoneum. The good thing here is whatever the mucosal incision which is made can be easily closed, and it is very safe because of this flap wall where there is a overlap of mucosa and the muscle layer for some distance. So you can create a mucosal entry point, go into the tunnel, and then create a mucosal or muscular defect, and still can close this mucosal incision very safely by the normal clips available in our day-to-day clinical practice. And the mucosa is a very strong structure which can prevent the contamination from the lumen into the vital structures of mediastinum or peritoneum. And that is why the principle of third space endoscopy lies on the fact that the gut wall can be split into layers. And if you separate those layers, you can do many things. Say, for example, you have a muscular problem because of the non-relaxation of lower esophageal sphincter known as achalasia. You can treat from orally. You can, previously we were using a laparoscopic approach to treat this muscular disorder. We can remove the tumors from the submucosa by submucosal tunneling and endoscopic resection. While if the disease is localized to mucosa, say for example, early cancer, you can separate these walls and get rid of this early mucosal cancer. This is a squamous cell cancer, early cancer of the esophagus. You have done separation of the muscle and mucosa by a technique known as endoscopic tunnel technique. This is known as DETT, digestive endoscopy tunnel technique. And then you can selectively treat the disease limited to mucosa or limited to muscle layer. And let us speak about the other modalities which can be treated, like, for example, there is a leiomyoma in the esophagus or a cyst in the stomach, or even if you can go through the muscular layer, take liver biopsies, or you can do a mediastinal lymph node sampling also. So now in 2022, with the advent of these issues, the new modalities, you can treat the diseases like achalasia, sub-epithelial tumor removal, refractory gastroparesis, Zenker's diverticulum, esophageal strictures, diverticulum, and even Hirschsprung disease. I'll quickly go through these. The principle is same, that you have to create a mucosal incision, go into the submucosal tunnel, and then after some length, create a mucosal flap wall, and then treat the muscular disease. So let us see. So this is the first step where you have to create a mucosal incision. Don't create the muscle incision there. So for that, you have to deposit some saline between the mucosa and muscle layer, create a bleb and cut. So you can create a mucosal incision, and subsequently you can get inside this tunnel. You can see there is a lot of dissection being done so that you create a space for your scope to go into this tunnel. Now, once you go into this tunnel, that is the difference, that is the tunnel between the mucosa and the muscle. And you can see now we are inside this tunnel. So this is step number 1, that is known as mucosal incision. Once you get into this tunnel, then you have to create a space by dissolving or dissecting this loose areolar tissue, which is on one side is muscle layer, on another side is the mucosal layer. And by this, you create a space. Now, you can see here, there is a separation of the muscle layer on the 6 o'clock and mucosa on the 12 o'clock. And now, in cases of achalasia, where the muscle is spastic, you want to get rid of the spasm. So you cut this muscle safely because you have created a separation between mucosa. Mucosa is right at 12 o'clock, and you can cut through and through. You can cut deep, and you can cut whole muscle, not only circular, but also longitudinal fiber. You can expose the mediastinum. You can see here we are exposing the mediastinum, and thick muscle fiber, which is not allowing food to go inside, is being released. But we are taking utmost precaution not to injure this mucosa. And once you do that, your job is done. That means, see that this is the LES, which is very spastic. And you have to get rid of this spastic segment, taking care that mucosa is not damaged. And once this is done, and now you have to come into the stomach. And then once you come to the end of this tunnel, your job is finished. Now you have cut the lower esophagus, you have cut the LES, and now into the stomach. And once you do that, you can see how nicely the muscle is completely cut, but mucosa is preserved. And you have got rid of the spastic LES. Now a patient will be able to swallow. And once you complete this, you have to close this mucosal incision. And you can see the muscle incision is not coinciding with the mucosal incision. And by simple hemoclip, by simple approximation of this mucosa, you can achieve a full thickness like closure. So this is how you can close the mucosal incision, or you can use some advanced technology like endocinch to close this incision, or you can use many other things also. But mostly hemoclips are enough. You can also treat not only achalasia, but other esophageal spastic disorder like DES or jackhammer's esophagus, where you need to do a very long esophageal myotomy. These patients are very sick. They have very severe pain, and you can see how nicely you can get rid of this spastic disorders, and the patient is able to swallow very nicely. This is the pre-poem barium swallow, time barium swallow, where there's a complete spastic esophagus. There is no emptying of the barium. And once you do the poem, the spasms are gone, and there is a good clearance of this barium within 2 minutes. The whole pain is gone, but this can be only achieved by per-oral endoscopic myotomy. And we have published many papers and shown that this procedure is very good in achieving not only clinical, but also objectively. You can say that even 400 patients we have published shown that there is a good objective response in the form of not only improvement of Eckhart score, the LES pressure, the IRP, the barium emptying, all improve significantly, and it lasts long, at least 3 years in our series, but now we have 10 years data also showing a very good response. But there are some problems, like if you have an unhealthy esophageal mucosa or there is a scarring, then you should wait for some time till that the unhealthy mucosa heals, because you want mucosa to be healthy. There can be submucosal fibrosis. There can be a sigmoid esophagus, which can cause some of the challenges, including the bleeding, mucosal injury, submucosal fibrosis, and may lead to technical failure. There are certain points which needs to be understood, that you are have to use CO2. And once you are using endoscope in third space endoscopy, you are bound to get capnopericardium or retroperitoneal space air, or even there can be air into the pleural space, causing some of the gas-related problem, which can be easily tackled by draining these CO2 out or waiting for some time for CO2 to absorb. We also know now the mucosal perforation should be dealt with. There can be some of the late presentation in the form of leakage leading to pleural effusion or empyema, which needs to be addressed in these patients. If you see the long-term outcomes, the major criticism of this procedure is that it may lead to reflux, because you are not doing any fundoplication. But now we are also doing endoscopic fundoplication along with the poem. And you can see here, this is the poem which is done, and you can go into the peritoneum now, and then you can see here we are exposing the liver, and on the left side there is a gastric fundus. And you can grab this gastric fundus into the tunnel to create a wrap like this. And then there can be a reduction in post-poem reflux. And the data is now developing on this and has shown that once you do endoscopic fundoplication, the reflux, the 24 hours pH metry is showing much, much better result as compared to those patients whom we are not doing fundoplication. But fundoplication is not required in not all patients develop reflux. So majority of the time we are doing poem on posterior aspect. And if the patient is developing GERD, we are treating them with PPI. And if they are PPI refractory, we may refer these patients for laparoscopic fundoplication or transoral fundoplication anteriorly, or you can also do another anti-reflux procedure, which are like TIF or GERD-X. So there are many options available, but requirement of such procedures is minimal. Around 10 to 20% of the patient may have a refractory GERD symptoms, may require some of the treatment. Coming to other modalities which can be used to treat is removal of subepithelial tumors. The subepithelial tumors may be in the submucosa or arising from muscle. These tumors can be easily removed. Again, the dictum, the procedure is to create a submucosal tunnel and then going into this tunnel, exposing the tumor. This is the tumor, but not disturbing the muscle layer and the mucosal layer. And you can bring out these tumors from the tunnel very, very easily using the third space endoscopy. And you can see now the tumor is being exposed and removed completely from this tunnel. And then subsequently you can clip off this mucosal incision. The advantage of this procedure is that it is minimally invasive and it requires less hospital stay. You have a full specimen available for histopathology. However, the training is difficult, and sometimes in patients who have malignant GIST are not proper patients for these. And you can do all these procedures, including submucosal tunneling, endoscopic resection, or even endoscopic full thickness resection using this technique. You can also now treat refractory gastroparesis when there is a pyloric spasm, especially those patients who have post-operative gastroparesis. And you can see in those patients, there is a tight pyloric channel because of the spasm, because of the vagus injury. And you can do this pyloric myotomy using the same technique, creating a mucosal incision, then going into the tunnel, exposing the pyloric channel, and then you can do the myotomy using the same procedure. You can see the muscle is being exposed over there, and you can see now the tunnel is extended into the duodenum, and then same technique where you can release this pyloric spasm. The problem here is you can see now we are using this knife to cut the muscle, which is responsible for the gastroparesis. But this treatment cannot be recommended for all gastroparesis, especially diabetic gastroparesis, where there are many. It is a multifactorial disorder where there can be a gastric atony, but the patients who have post-operative gastroparesis can be treated by releasing this muscle, the cutting a muscle and releasing this pyloric channel, and you can have a very nice opening of the pylorus, and the gastroparesis may resolve. But challenge here is choosing the right patient. You can do many procedures, including patients who have large esophageal diverticulum. You can cut this muscle septum between the diverticulum and the lumen. This is known as diverticular poem or D poem, where we expose the septum between the esophageal lumen on one side and the diverticular lumen on the other side, and cut this septum and get released the diverticular septum. I'll just expose this. You can see here by this procedure, you have exposed the septum between the mucosa, between the esophageal lumen on the left side and diverticular lumen on the right side, and cut this septum. With the want of time, I'll skip this video. And also, we are now treating Zenker's diverticulum using third space endoscopy, where the septum between the diverticulum and the esophageal lumen is exposed under the cover of mucosa. The advantage here is by the conventional technique, usually we have a fear that we may undercut, and then patient may have recurrences, or you may overcut, where the patient may have perforation. But if you're doing Zenker's diverticulectomy under mucosal cover, you can do a longer myotomy like this, and there is no fear of perforation. And once you complete the procedure, you can close this mucosal incision and come out. That is known as ZOM. We are now also treating difficult esophageal stricture. This is the stricture area. You can approach from below and above and create a tunnel and reach to the scope which has been placed through the PEG tube, and then you can reach out to this scope and put metal stent across and improve the continuity. And also, we are now treating patients with Hirschsprung disease. You can see there is a spastic segment of muscle at the anorectal junction and extending not more than 4 centimeters. And then you can cut this spastic segment by, you can see this is the dilated segment of the rectum. And then there is a small spastic segment of the muscle, again creating a tunnel by mucosal incision and then cutting the spastic segment. I'll not go into the detail because of the want of the time, but again, the advantage of third space endoscopy here is you are not breaking the mucosal integrity, but cutting the muscle under the mucosa. And you can see this is the spastic segment of the muscle, which is not allowing the stool to pass down. And this is known as Hirschsprung disease, where a big surgery may be required. And you can avoid this surgery by releasing this spastic segment of muscle and relieving these patients. So with this, I will say that we have traveled a lot, but third space endoscopy can be used in many other ways in the form of drug delivery into the submucosa. You can take full thickness biopsies in patients who have visceral myopathy or neuropathy. You can put the simulating or stimulating catheters inside the submucosa. You can do harvesting of the tissue for stem cell transplantation. And of course, there's a lot of things can be done with this technique, and time is there, which has shown many procedures, as I've enumerated, has been successfully performed in human cases, but there are many more things to come. With this, I will end my lecture over here and will thank the organizing committee once again for giving me this wonderful opportunity.
Thank you, Dr. Mohan, for the nice presentation, as usual. So we have just 2 questions for the stair. What is the maximum size for a submucosal lesion you will resect from the esophagus?
Yes. So esophagus is not a problem because most of the cases are leiomyomas. And even if you have a larger lesion, more than 5 centimeters, you can still do a piecemeal resection because leiomyoma are not malignant. But I'll be very careful in not disturbing the capsule in a gist, especially in the stomach. And if I don't break these tumors, so I will be able to do 4 to 5 centimeters in the stomach, but I have no limit for esophagus because even if I cut the tumor, it is okay. So if patient is not willing for surgery and if there is a dysphagia, I have even removed these patients of around 8 to 9 centimeters of leiomyomas. But of course, that will be piecemeal removal, and you may not be able to completely remove in toto. But I will be very careful about the gist.
So, and the other question, in the case of the esophageal diverticulum, I see you create a nice tunnel and you separate the septum, but I'm not sure if you start the myotomy from behind or you are going to cut the septum first. Which you will cut first? You will cut the septum or you start the myotomy in the septum?
That's a very good question. So what we have seen is some majority of these patients also have associated motility disorder. So you have to not only cut the septum, but also cut the muscle into the esophagus and direct your cut into the stomach, so that your septum should be involved in the long myotomy of esophagus and stomach. But if your manometry has ruled out any background motility disorder, then it is okay to cut only the septum. But as I told in our series, they are also associated. Why the diverticula is formed? That may be because of underlying a motility disorder. So to do a good barium and also to do a manometry is of very important. And if you have an associated abnormality of non-relaxation of LES, or there can be a jackhammer's esophagus, then you have to do long myotomy and cut septum. But if there is no manometric abnormality, only cut septum.
But which you will cut first? You will cut first the septum, or you cut standard myotomy in the septum, technically?
I think I cut the standard myotomy, but always keep in mind, where is my septum? I'll direct the myotomy right into that direction. And while I reach to the septum, I cut the septum along with the myotomy, which I am cutting from proximally.
Yes, thank you. Thank you. Thank you for the nice presentation. It's always our pleasure to be with us. Thank you. And now we invite our third speaker, Professor Ali Gaballa. He will talk about eosinophilic esophagitis.
Bismillah ar-Rahman ar-Rahim. Dear Mr. Chairman, dear professors and colleagues, I have the pleasure to be here and present this short talk titled The Recently Described and Commonly Missed Entity Eosinophilic Esophagitis. At the very beginning, I'd like to thank Professor Nabil Omar, head of the Congress and of the department, and Professor Muhammad Aql for inviting me to share in this distinguished meeting. At the beginning, eosinophilic esophagitis, as all of us know, gained increasing recognition, especially during the last 5 years. And despite this, many clinicians remain unaware of this entity from the diagnostic and therapeutic points of view. And this would result in a diagnostic delay, which has been estimated to be from 4 to 6 years in patients with eosinophilic esophagitis. بيبقى التشخيص متأخر من 4 إلى 6 سنين. The history of emergence of this entity took several steps. First, it was described in 1994 as a new entity, and in 1995, food as the principal trigger or the principal antigenic trigger for this immune-mediated disease was demonstrated. Later, in 2007, there was the first guidelines for the eosinophilic esophagitis management by the International Expert Committee, and the increase in interest thereafter occurred with more than 200 publications yearly. Later, the American College of Gastroenterology published the first clinical guidelines, American guidelines, which has been updated later in 2018 by an international consensus. The latest advance in the publication is by the American Gastroenterological Association and the Joint Task Force on Allergy Immunology Practice Guidelines, where they postulated and published evidence-based management for this entity. These are the different titles we are going to go through rapidly. Now, by definition, it's an immune-mediated disease leading to chronic inflammatory process and fibrosis leading to esophageal dysfunction characterized by eosinophilia of the esophageal mucosa. Later, in 2021, Visagi added to this definition that we should exclude other secondary causes for eosinophilia of the esophageal mucosa, as well as stressing that the main cell concerned with this immune process is the T helper type 2 cells. Now you can see in this slide the increasing incidence and prevalence of eosinophilic esophagitis, and there is a drastic increase across the United States and all over the world, approaching to a prevalence equivalent to the prevalence of Crohn's disease. 1/4 of patients presenting to the endoscopy department for dysphagia proved to have eosinophilic esophagitis, and about half of the patients presenting by food bolus impaction proved to have eosinophilic esophagitis. These are statistical data regarding the sex incidence, the peak age incidence between 20 and 40, and 80% of the patients has allergic diseases. 80% would have bronchial asthma, for example, urticaria, allergic rhinitis, other allergic diseases. This is the main principal pathogenetic mechanism, which is the impaired mucosal barrier of the esophagus, allowing the food allergens to pass, and this would invite reaction by the T helper type 2, leading to secretion of cytokines, mainly interleukin 13, 4, and 5, inviting the eosinophils and its degradation, as well as the fibroblasts to secrete fibrous tissue. The main concern in this impaired eosinophilic esophagitis is in the impaired mucosal barrier, where it is genetically determined by more than 31 genes, with other several weak environmental factors, like, for example, maternal intake during pregnancy of antibiotics, acid-suppressing agents. Now, the diagnosis for this entity would be based on 4 items. Item number 1, the clinical symptoms, whether inflammatory or fibronodular. In a patient, as we mentioned, with allergic diseases, histologic confirmation is mandatory, and exclusion of the secondary causes. These are the 4 corners to diagnose this disease entity. The clinical presentation would rather differ according to the age and whether the presentation is by the inflammatory process or by the fibronodular and fibrostenotic presentation. And you can see from this slide that it starts in young age as an inflammatory disease and progresses with age to the ultimate outcome of fibrostenotic disease. And so the clinical presentation can be grouped either inflammatory, GERD-like symptoms, abdominal pain, etc., to the fibrostenotic presentation, mainly by dysphagia, bolus food impaction, chest pain, regurgitation. Symptoms are not enough for the diagnosis because these symptoms may mimic GERD symptoms, as well as the adaptive mechanisms used by most of the patients to overcome the swallowing difficulty, like, for example, slow mastication, drinking water excessively during eating, avoidance of solid food. And in order to standardize the symptomatology, several scoring systems are there for the symptoms, including adult scoring systems and children scoring systems. Endoscopy and histology. طبعا endoscopy and the biopsy are crucial in the diagnosis. And you can see in this slide the characteristic endoscopic appearance where the esophagus looks like the trachea, or what is termed trachealization of the esophagus. And the abnormalities are age-related according to whether it is inflammatory or fibrostenotic. There is a scoring system for the endoscopic classification termed the endoscopic reference score, taking into account the 5 main macroscopic abnormalities during endoscopy, which is edema, rings, exudate, furrows, and stricture. And patients are grouped according to this scoring system, taking, as you can see, stage 1, stage 0, stage 2, and this is to standardize the follow-up of these type of patients. Unfortunately, 1/4 of patients with eosinophilic esophagitis show no macroscopic endoscopic abnormalities, and so histology is mandatory. Biopsies are mandatory to the diagnosis to evaluate the presence of eosinophilic infiltrates as well as other additional histological abnormalities. Now, the histologic diagnosis is confirmed when more 15 or more eosinophils are counted per higher power field in a biopsy specimen. And please take care, the biopsy specimens are taken from the proximal and the mid-esophagus. The normal range is 1 or less than 1 eosinophil per high power field. This is the technique of biopsy taking, where you can observe from this slide 6 biopsies are required. And if there is macroscopic abnormalities, it's better to take the biopsies from these areas. Secondary causes for abnormal eosinophilic infiltrate in the esophagus include primary causes, and secondary causes should be excluded. Now, the problem comes from the differentiation from GERD, where GERD affecting 30% of the population, which is a very common problem, may be mistaken for eosinophilic esophagitis and vice versa. Here, the distinction can be made either by the presence of GERD complications or, in more difficult cases, by the ambulatory pH monitoring and the mucosal impedance testing. Now, what is the treatment regimen for this entity? The treatment regimen includes the 3 Ds. 3 Ds, drugs, diet, dilatation. Regarding the first entity, drugs, proton pump PPIs gives a response in the initiation of remission and its maintenance from 30 to 50% of patients. And this group of patients are termed the PPI responsive eosinophilic esophagitis. And this would add difficulty and delay in the diagnosis. Patients may come presenting by GERD-like symptoms. PPI were prescribed, the patient improved, and so the physician and the clinician, or most of the clinician, will be satisfied by this improvement and this outcome, and the diagnosis here will be delayed. The first recognition that PPI are effective emerged in 2011 and has been evidence-based in 2017. According to the AGA recommendations, PPI should be given in a full dose for 8 weeks. Several therapeutic mechanisms has been postulated why PPIs are effective in controlling the symptoms of patients with eosinophilic esophagitis, including its anti-inflammatory effect, including their acid suppression effects and their suppression of the T helper type 2 type of cells. Vonoprazan, or the new group as acid suppression, the potassium competitive acid blocker, can be used if PPIs fail. So PPIs are the first choice in the induction of remission and its maintenance. However, symptoms recur if you discontinue this PPI. The corticosteroids represents the mainstay for eosinophilic esophagitis therapy, being immune-mediated disease. And here we have no systemic side effects from these topical steroids except for esophageal moniliasis. Two preparations are commonly used, the budesonide and the fluticasone propionate. This is the budesonide, aqueous solution or orodispersible tablets, and this is the fluticasone propionate. Now, the efficacy of using steroids reaches up to 66% of patients. Now, the second is the diet. Diet, its role is the main antigenic trigger for the process, and so to treat the cause, you should modify the diet. And we have here 3 strategies. Strategy number 1, elemental diet. Strategy 2, empiric elimination diet. And strategy 3, food allergy testing guided elimination diet. elemental diet ده عبارة عن sachets liquid formula، يعني احنا بنخلي البيشنت يوقف اكل خالص وبيمشي على الليكويد فورمولا. طبعا this is something which is not practical, but astonishing enough you can observe here that the efficacy in inducing remission اكتر من 90% من غير drugs, without drugs. طبعا في drawbacks for this elemental diets، من ضمنها انها بتبقى بروسيدور معقده لانه بنبتدي introduce food every week بعد فتره انقطاع شهر ونص عن الاكل والاعتماد على الليكويد فورمولا دي، بالاضافه للبور توليرابيلتي والادهرنس والكوست بتاع البروسيدور دي. The second strategy is the target elimination diet اللي هي باستخدام الفود allergy testing either by the pinprick or by the atopy patch test. However, الداتا هنا ما بتبقاش sufficient because these tests are not sensitive and are not accurate in assessing the exact food allergy. ممكن حاجات تطلع نيجاتيف يجي البيشنت ياكلها يحصل triggering للبروسيس. And so this target elimination diet can be helpful more commonly in children than in adults. Finally, the empiric elimination diet ده بيعتمد على ان احنا بنشيل النون foods to trigger الالرجي in general وبالتالي الاوزينوفيليك اسوفاجايتس. وهنا في الابروتشز في 3 اصناف. في حاجه اسمها 6 فود اليمينيشن دايت بنشيل فيها الفيش والويت والميلك والاج والصوي والنتس، بتدي نتيجه اكتر من 70% efficacy in controlling the symptoms and stopping the immune mediated reaction.
ولو سمحتوا الصوت اللي ورا بعد اذنكم مش سامعين منكم، فمعلش نسمع المحاضره.
شكرا يا بيه. البروتوكول بيبقى منع ال6 اصناف دول لمده شهر ونص، وبعدين بعد كده gradual reintroduction by in a stepwise manner 2 items ب2 items، ويعقب كل introduction منظار وهيستولوجي. طبعا عمليه برضو معقده. في نوع تاني اللي هو 4 فود اليمينيشن اللي هو بيمنع الويت وبيمنع الميلك والاجز والليجيومز. طبعا النتيجه بتاعتها اقل من ال6 فود اليمينيشن ب 64%، الثانيه كانت فوق 70% نتيجه. في التو فود اليمينيشن دايت اللي هو بيتركز على الميلك والجلوتين فقط، وهنا الافيكاسي بتاعها بتبقى اقل، بتبقى 40%، يعني 70 60 40%. في طريقه بقى عملوها بوستيوليتد جديده، ان يمشي بحاجه اسمها 2-4-6 فود اليمينيشن دايت ستيبس، اللي هو يبدا الاول بانه يعمل ريستريكشن لتو ايتمز، بعد كده لسه في اكتيفيتي يعمل ريستريكشن لفور ايتمز، لسه في اكتيفيتي يعمل ريستريكشن للسكس ايتمز. طبعا في باريرز كتير لنجاح الدايتري ثيرابي ده، وفي ريكوايرمنتس كتيره فور ايتش سكسس، عايزه مالتي ديسيبلينري تيم، عايزه اكسبيرينسد دايتيشن، في كروس كونتامينيشن طبعا مع انواع الاكل اللي احنا بناكلها بحاجات اخرى، مش كل حاجه بتبقى بيور. الويت فور اكزامبل بيبقى عليه راي وبيبقى عليه بارلي. المينتننس بتاع الطريقه دي صعبه جدا، وكذلك الادهرنس بتاع البيشنتس للطريقه دي مش سهل، ودي كلها تعتبر دروباكس للدايتري ثيرابي. اخر حاجه خالص نختم بيها الاندوسكوبيك دايلاتيشن. الاندوسكوبيك دايلاتيشن ده is reserved for patients with dysphagia and fibrostenotic lesions، وطبعا بيؤدي لنتيجه ممتازه، بيحسن 95% من البيشنتس بعد 3 سيشنز، مع طبعا several precautions من الدايلاتيشن ده الاندوسكوبيك دايلاتيشن. في حاجات بقى جديده في الفيوتشر بتاع الفارماكولوجيك ثيرابي، زي استخدام الانتي الرجيك ميديكيشنز، زي الاستخدام الكيموتاكتين ريسبتور تي هيلبر انتاجونست، زي استخدام الاميونو سبريسيفز، وزي استخدام البيولوجيك ايجنتس اللي بتكاونتر اكت ذا انترلوكين 13 و4 و5 with promising results in the future like this photo. طبعا ده ملخص او سمري للتريتمنت اوت كم، وهنا في ملخص برضو للمميزات وعيوب كل طريقه. At the end I'd like to tell that eosinophilic esophagitis is a recently described condition. Well, unawareness of the clinician may lead to diagnostic delay من 4 ل 6 سنين على ما العيان يتشخص، وان الكلينيكال presentation is variable according to the age and the phenotype present. لان التريتمنت استراتيجي هم الثلاثه دي، وان التريتمنت اوبشن should be individualized حسب ظروف كل patient، وان الاجا وجوينت تاسك فورس جايد لاينز 2020 represent the most recent update for the treatment. Thank you very much.
شكرا دكتور علي على المحاضرة الجميلة، ودايما بيبقى محاضرة ساعتك ابديتد سلسة بس ابديتد جدا. اظن احنا في ديليد 1 اور، فاحنا انفايت تو نيكست سيمبوزيوم حكمة سيمبوزيوم بروفيسور ايمان فوزي، بروفيسور بروفيسور محمود علام، بروفيسور محمد عباسي، بروفيسور سوسن عبد المنعم، بروفيسور طلعت زكريا and Professor وائل عبد الرازق.
Thank you, Professor Magdi. But before this session, Global NAPI will present their products in just 5 minutes. اتفضلي. اتفضلوا حضراتكم chairperson. اتفضلي chairperson.
مساء الخير. أنا مريهام Product Manager من Global NAPI. Today أنا هاخد 5 minutes بس هتكلم عن our portfolio, our company. We will start with the company. Global NAPI is one of the top 10 company. احنا السنة دي بنحتفل ب 25 سنة على Global NAPI. Our co-founder is Dr. Makram Mahanna. Dr. Makram Mahanna, he is one person who has a lot of establishment in the pharmaceutical industry, and هو founded Global NAPI founded 1997. That's why احنا بنحتفل ب 25 سنة Global NAPI السنة دي. وعشان كده احنا دايما بنحب نأكد ان Global NAPI is one of the top 10 company بأيادي مصرية. We have a mission and a vision. Our mission دايما ان احنا بنقدم products with a good quality with affordable price للبيشنت المصري, plus علشان to share in the creation of healthy smile لي. وكمان احنا عايزين نأكد ان في فترة الكوفيد احنا قدمنا a lot of products بتساعد على الشفاء طبعا من الكوفيد as the Pyroglobe والبيروستافير. بلس الحاجة المهمة جنب اللي أنا كنت عايزين نتكلم عليها هنا خصوصا في Liver Institute Conference إن Global NAPI ساهمت in virus C elimination اللي كانت معمولة من 2-3 سنين على أساس هافر هاب والدكلة والريبة. و it's one of the dreams بتاعت دكتور مكرم مهنا كانت إن هو كان يساهم في 2020 أو كانت 2021 مصر خالية من فيروس سي. طيب احنا طبعا احنا integrated company we have importation, production, marketing, distribution. part من البرودكشن بتاعنا ان احنا عندنا 3 factories. اول حاجة هو GMP وده founded 98 plus GPI ده founded 2011 وهو ال only sterile factory حاليا في الميدل ايست. بلس ان احنا عندنا جاب ده فاوندد 2016 وكان من اهم البرودكتس بتاعته المونو دوز اوفثالمولوجي برودكتس. بلس احنا بنصنع لشركات كتيره مالتي ناشونال فايزر, ساندوز, روش, سانوفي. a lot of credibility in our factories. بلس ان احنا عندنا a lot of importation products في البلاد اللي احنا شايفينها زي بولند, زي اليمن, نورث كوريا, هونج كونج. وعندنا 3 مصانع بره مصر منها في اثيوبيا والسودان وسعودي ارابيا. و a lot of our products حاليا بنشتغل عليه بروموشن اكتر من 150 product واللي هنتكلم عليهم النهارده هي GIT products. our products عندنا هو النابيزول. النابيزول هو عمره من عمر جلوبال نابي, هو اول برودكت فاوندد ان جلوبال نابي وبيتميز بان هو بيلس تكنيك. والبيلس تكنيك هيز فيري يونيك للنابيزول لانه بيحافظ على البي اتش بتاعه الاستمك اكتر من 24 ساعه نتيجه ان هو delayed release products. بلس احنا عندنا النابيزول فايل available in market مع النابيزول كبسول. Another product for us is the Zomigibral. Zomigibral هو اسمه برازول موجود على هيئة IV برضو موجود في one products. Other product is Pepra. واحنا دايما مع البيبرا رابي برازول 20 ملغ. بنأكد ان احنا برضو بنحافظ على الانتراجاستريك بي اتش اكتر من 4 compared للبانتوبرازول بpercent of time اعلى بكتير سواء كان during night time سواء كان day time او ال 24 ساعة period. واحنا available enteric coated tablet 20 ملغ ديلي. البرودكت الثالث عندنا تريتو-ألس. تريتو-ألس هو كومباينيشن ما بين الأوميبرازول والصوديوم بايكارب ودايما الكومباينيشن دي علشان بنحافظ على الاستابيليتي بتاعة الأوميبرازول علشان بيبقى أي بي بي اي هو أسيد لابايل فذاتس واي الصوديوم بايكارب added. واحنا بنشتغل طبعا حالات الجبناين gastric ulcers, duodenal ulcer, GERD والإيروسوفيس esophagitis بلس الجانتوليف. الجانتوليف هو ايتوبرايد هيدروكلورايد، والايتوبرايد has a lot of benefit منها ان هو inhibit الاسيتايلكولينستريز D2 antagonist في الجد والسي تي زد، وده بيخليه يسرع الجاستريك امتنج وبيزود البريشر بتاعه ال LES، مع ان هو بيحسن الجاستروديودينال كوردينيشن. We are available in market Gantoleaf 30 tablet, 1 tablet 3 times daily before each meal. طبعا لحالات الفانكشن ديسبيبسيا والجيرد. اخيرا البرودكت بتاعنا كافيكلود. كافيكلود هو انتيكافير 0.5 ملغ و1 ملغ، وطبعا هو لحالات ال HPV لانه بيعمل انهبشن للبرايمينج بتاع ال HPV بوليميريز، وبيعمل ريفرس ترانسكريبشن بتاع نيجاتيف ستراند DNA from the pregonomer messenger RNA plus synthesis of positive strand of HPV DNA. احنا available في الماركت طبعا ب patient support program. We have powerful triple action HPV, low أو abscess viral resistance و favorable tolerability. Thank you. ميرسي لوقتكم جدا، وأتمنى دايما إن mind. Thank you.
We now start our session, Challenges in Liver Transplantation. Definitely post-liver transplant rate, survival rate has improved markedly over the past years, but still there remain some challenges. This is what we'll discuss in our session with our eminent speakers. I'm also honored to have eminent chairpersons with me, Professor Iman Fawzi, Professor of Tropical Medicine, Serial Transplant Hepatology Consultant at Ain Shams Center for Organ Transplantation. My colleagues at the National Liver Institute, Professor Mohammed Abbasi, Professor Mahmoud Allam, and also Professor Wael Abdelrazak, who's also the head of primary healthy care and nursing sector at Ministry of Health. At first, we're going to discuss an important subject, which is rejection management. Although there has been a great advance in immunosuppressive therapy, making death or need for transplantation due to rejection much uncommon during the first 10 years, there still remain some arguments about certain issues, such as the optimal dose of steroids in T-cell mediated rejection, the recently defined antibody-mediated rejection, and these issues will be covered by our first speaker.
So now it's give me all the pleasure to introduce Professor Mona Al-Amir, Professor of Internal Medicine, Hepatology, Gastroenterology, and member of the European Association of Study of Liver Disease and the European Society of Transplantation, one of the eminent consultant of liver transplantation and the founding member of Ain Shams of Asr Al-Aini School of Liver Transplantation. Dr. Mona will give us a talk about the challenges in rejection management post-liver transplantation.
Thank you, Professor Iman, for your nice words and introduction. I'd like to thank the organizing committee and in particular Professor Nagla Alam for the kind invitation. I'm really honored to be with you today. Improving long-term patient and graft survival after liver transplantation remains a major challenge. Despite recent advances in immune suppressive agents, allograft rejection remains a common complication after liver transplantation. It was previously thought that there were 4 main types of rejection, as we all know: hyperacute, acute, chronic, and humoral, but redefining the liver transplant rejection by the Banff Working Group in 2016, defining the main categories as T-cell mediated rejection, antibody mediated rejection, and chronic rejection as 3 main categories, with each one has 2 subtypes. To diagnose, we need histopathology, which is a mainstay, clinical findings, and also various serum studies. These are the main categories of rejection. What about the serum studies or the biomarkers? We have antigen-specific assays, antigen non-specific assays, and DNA markers, but unfortunately, none of these methods have been able to be verified for use in the clinical practice. Apart from the DSA or donor-specific antibody, as we know, is applicable or practically used, but with also a limiting factor, which is this test requires a significant amount of cells and blood. So, the most specific way to monitor for rejection is biopsy and histopathology. What about treatment? Starting with the first type, which is T-cell mediated rejection, which is subdivided into early and late. Starting with the early type, early TCMR. As we all know, it is the commonest type of rejection. It occurs in 10 to 40% of cases in the first months or during the first months post-transplant. The standard of care depends on the severity of the RICE score. If it is less than 4, it is defined as mild. 4 to 6, it is defined as moderate. 7 to 9 or more, defined as severe. Then, if it is mild, either no treatment or just a mild increase in immune suppression. Why? What is the rationale? The rationale is the potential of this mild rejection to self-resolve. And on the other hand, the side effects associated with using more potent immune suppressive drugs. Then, what about moderate and severe? The corticosteroids are the first-line treatment of moderate and severe acute or early TCMR. So the question is, what is the optimal dose of steroids? This controlled clinical trial comparing two groups, comparison between two high doses of methylprednisolone. Group 1 received 1 gram on the first day with on the second day 200 milligram and then tapered by 40 milligram every day for 5 days. On day 7, the baseline dose 20 milligram. The other group or group B received methylprednisolone 1 gram per day for 3 consecutive days, and on day 4, the baseline dose 20 milligram received. And they concluded that the first regimen was more effective and also safer. This another important study on 176 consecutive liver transplant recipients, 43 episodes of acute rejection was reported. All the patients received the protocol of 500 milligram daily for 3 consecutive days. What about the response? It was 79% responding to steroids, only 14% considered methylprednisolone resistant, for which they received the ATG or antithymocyte globulin. The remaining 7% just adjusting the level of immune suppression. What about the ATG? The ATG is antithymocyte globulin. It's an antibody preparation derived from rabbits or horses. It acts against human T cells and their precursors. Several studies actually have shown resolution of steroid-resistant rejection with ATG, but we have to know that the most common side effects experienced: fever, chills, arthralgias, abdominal pain, leukopenia, and anemia. And on the long run, the long-term risks are opportunistic infections and malignancy, especially PTLD. The next type, which is the late TCMR. The late TCMR, how to manage? First, we have to know that its incidence ranges between 7 to 23%. It occurs between 90 and 180 days post-transplant, and the main cause or the main patient is a non-compliant patient, the patient with low levels of immune suppressive drugs. Also, the use of cyclosporin instead of tacrolimus may be a factor, taking 2 drugs instead of 3, and not including MMF, all are factors or risk factors. How to diagnose? The pathological findings are quite similar, with slight differences from the early acute rejection, and fortunately enough, the vast majority successfully managed by or with steroids. The next type, which is AMR or antibody-mediated rejection, we have to look to this algorithm. Usually it is a steroid-resistant, diagnosed as MR. It's subdivided into acute and the chronic, and we have to know that the first treatment is plasmapheresis, IVIG, and then rituximab as rescue therapy. Bortezomib and eculizumab for the acute type are the novel agents. On the other hand, the chronic is bortezomib is the first line of therapy, and another investigational treatment, clazakizumab, is under investigations. More details about the AMR: it occurs within the first few weeks after transplantation, and according to the BANF working group, the recipient must meet all the 4 criteria: histopathology, specific histopathology, positive serum DSA or donor-specific antibody, diffuse microvascular C4D deposition, and reasonable exclusion of other insults. Unfortunately, usually it's under-recognized with complexities in diagnosis and treatment protocols. The treatment in the literature restricted or limited to case reports and small series. This was a case series from Montreal, Canada, reported 4 cases of antibody-mediated rejection or AMR. The treatment following a course of steroids included IVIG for the 4 cases, plasmapheresis for 3 out of 4 cases, and ATG for only 2 cases. 2 patients developed complications, including infections and lung adenocarcinoma, and 1 patient died from pulmonary aspergillosis, and they concluded that AMR is rare but possibly underdiagnosed condition. Very important. It should be suspected in any patients with steroid refractory rejection. The mainstay of treatment, as we said, for the AMR, acute AMR, is plasmapheresis and IVIG. Why? Theoretically, they remove the antibodies mediating the rejection, but other modalities, the novel agents experimented are the rituximab as rescue therapy, which is anti-CD20 antibody, the bortezomib, which is used in the treatment of multiple myeloma. It's a protease inhibitor acting against B cells and plasma cells. And the third one, eculizumab, which is monoclonal antibody. On the other hand, the late AMR, we go to bortezomib as first agent to treat. No rituximab in such a condition, and another investigational drug, clazakizumab, which is the pilot studies or the pilot trial on it need to be completed to be applicable in the field of transplantation. This paper about the use of rituximab as rescue therapy early in the literature, actually for refractory early acute rejection. Also, it is used as single dose prophylaxis 2 weeks before transplantation if it is incompatible, ABO incompatible LDLT, which is not applicable in Egypt. Bortezomib actually early since 2012 showed excellent results, improved in this case 3 cases reported. It showed excellent results with resolution of C4D deposition and DSA and improvement of liver functions. Also, another more recent study, bortezomib, a new promising therapy for early antibody-mediated rejection after liver transplantation. Also, this study reported excellent results with acute AMR, but they're recommending more studies to prove its efficacy in the chronic AMR. This very recent study, 2022, reported also excellent results with using bortezomib with everolimus in the acute AMR. What about eculizumab? Eculizumab also in this case report, they reported 2 cases treated with single dose, 600 milligram, and they concluded that it was safe, associated with clinical, immunological, and the histological improvements in both cases or both recipients. But further studies are needed actually to put protocols for diagnosis and the treatment for AMR. Coming to the last category, which is the chronic rejection. As we see, if the patient on cyclosporin, we have to switch to tacrolimus. If the patient receiving tacrolimus, we have to increase the dose or add or after that additional agents, especially mTOR inhibitors. So we can conclude that as regard the chronic rejection, it's, as we all know, separated into early and late, but it is not the matter of timing, it's a matter of histopathology, and the biopsy could be mixed. Anyway, the treatment is either escalation of immune suppression or if no response, unfortunately, retransplantation is the only solution. But we have to know well that the using or addition of mTOR inhibitors has shown to reverse the chronic rejection in approximately half of the patients, which is a high percentage. Actually, this meta-analysis showing the incidence of chronic rejection in various studies and the response to treatment. So our take-home messages, there are three main categories of rejection as defined by the Banff Working Group. Early TCMR is the most common type of rejection. There are currently, unfortunately, no non-invasive, cost-effective, accurate biomarkers or serum study, serology study to diagnose. As regard the standard of care, the RICE score guides the initial treatment of early TCMR. The first-line treatment, as we all know, is high-dose steroids. When the patients are refractory to high-dose steroids, we should consider the AMR. This is an important point. The only effective approach for treatment of chronic rejection in the literature to switch from the cyclosporin to tacrolimus. More data on the management of acute and the chronic AMR with novel immune suppressive agents we mentioned, and multi-center studies are actually required. Thank you.
Thank you, Professor Ramona, for this very nice updated literature. I know we have a lot of questions, but we will keep questions for the end of the session.
As we know, hepatocellular carcinoma and cholangiocarcinoma have become accepted indications for liver transplantation. Yet more studies seeking to expand the ongoing indications for liver transplantation, the expanding oncologic indications are emerging. Liver transplantation in the setting of hepatic and non-hepatocellular liver-limited gastrointestinal malignancies will be covered in the next presentation.
It's a pleasure to introduce Professor Dr. Asma Goma, Professor of Hepatology and Gastroenterology in National Liver Institute and Fellow of the Royal College of Physicians. She will share us her experience with liver transplant for malignancies, extending the criteria.
Thank you, Professor Muhammad, for the introduction, and thanks for the organized committee for a kind invitation. I'll talk about liver transplantation for malignancies, expanding the criteria. My agenda will be liver transplantation for hepatocellular carcinoma and cholangiocarcinoma and colorectal associated liver metastasis. First, hepatocellular carcinoma. As we all know, the only curative treatment options for hepatocellular carcinoma are liver resection, ablation, or transplantation. Transplantation cures the tumor and the diseased liver. So, can we perform liver transplantation for all patients? The answer is no, because we are afraid of recurrence. Till now, there is no diagnostic test that can detect microscopic seeding that will form metastasis later on, and also we cannot determine tumor behavior based on available radiological imaging or even biopsy. Besides the requirement for immunosuppression, which may result in decreased immunological tumor surveillance, and this increases the risk of tumor recurrence. The recent guidelines recommend liver transplantation for patients with hepatocellular carcinoma in very early stage, and for some selected patients in the intermediate stage. And this was based on multiple trials. The first was from University of Milan by Mazafiro and this group. They studied 48 patients with small unresectable hepatocellular carcinoma. The tumor was single lesion, less than 5 centimeters, or up to 5, or no more than 3 lesions, and the largest was not greater than 3 centimeters. And these criteria were preoperative by imaging. The overall survival was 75%, and the rate of recurrence was 83% after 4 years. But examining the explanted liver, they find that some patients exceeding these criteria, which are decided preoperative. And they found that patients who actually met the predetermined criteria on the explanted liver has an excellent 4-year overall survival of 85, similar to those patients transplanted without HSC. And hence the Milan criteria have been adopted because they help to predict patients are less likely to recur with with significant survival benefit. Other investigators try to expand these criteria. The first were from University of California, San Francisco. They analyzed the outcome of 70 patients transplanted with HSC. Some of them were incidental at very early stage, and some of them with a late stage with microvascular invasion. Based on the pathology of the explant, they found that solitary tumor up to not greater than 6.5 centimeter, or up to 3 tumors with the largest not greater than 4.5 centimeter, with total tumor diameter less than 8 centimeter, can classify patients significantly with better overall survival. 5-year overall survival was 72. Then they returned back to the preoperative imaging, and they found a concordance between the preoperative staging and the pathological staging. So based on preoperative radiological finding, patients who met the UCSF criteria had a 5-year survival of 83%. After that, other investigators tried to expand the Milan criteria. From Japan, they tried to put the BBK2, and they defined that BBK when not more than 400, they can transplant patients up to 10 in numbers, and all the tumor size not more than 5 centimeters. And the 5 recurrence rate for these criteria was significantly lower than patients exceed these criteria. Also, from China, they defined a new criteria with solitary lesion not more than 9 centimeters in diameter, or no more than 3 lesions with the largest not more than 5 centimeters, and total tumor diameter not more than 9 centimeters, without macrovascular invasion or lymph node invasion. So the group from Milan University analyzed in larger data about 1,500 patients transplanted. They found some of patients were within Milan, some outside the Milan, some had microvascular invasion, and they reported the up to 7 criteria, with 7 is the sum of the size of the largest tumor and the number of tumors. Patients who were in the up to 7 criteria achieved 5-year overall survival of 71%. And developed the original Metro ticket calculator that predicts the 5-year overall survival based on the histological features at the explant. If we put the size of the largest tumor and the number, they will give us the 5-year predicted overall survival. Moreover, it can be subclassified according to presence of vascular invasion or not. As we all know, the alpha-fetoprotein is a well-known prognostic indicator of vascular invasion and tumor differentiation. A group from France studied preoperative evaluation, and proposed a model combining the alpha-fetoprotein with tumor size and number. They classified the patient into two low-risk group and high-risk groups. Patients outside Milan with alpha-fetoprotein less than 100 can be classified as low-risk group in this model. Although patients within Milan can be classified as high-risk group if they have alpha-fetoprotein more than 1,000. And this figure clearly demonstrates a significant difference in survival rate and recurrence rate according to patients with high risk or low risk. Moreover, this model can stratify groups within the Milan or exceeding the Milan with highly significant difference between them regarding the rate of recurrence. This model highlights the relationship between alpha-fetoprotein and tumor behavior, and it was proposed to add the alpha-fetoprotein to tumor size and the number in the decision-making algorithm for selection of HSC patients for transplantation. And this was already done in Metro Ticket Calculator. This model used the number and diameter of the lesion besides the level of alpha-fetoprotein and can predict the 5-year overall survival and can be stratified according to presence of hepatitis C, and this is based on preoperative radiological assessment. So after we select the patients, the patient will go to the transplant list and he will go a mild exception if he is D2. I'll talk briefly about cholangiocarcinoma. Perihilar cholangiocarcinoma was initially liver transplantation was initially contraindicated for perihilar cholangiocarcinoma until large study uses new adjuvant chemoradiotherapy followed by liver transplantation and showed 5-year disease-free survival of 65%. And the ILS recommends that liver transplantation for perihilar cholangiocarcinoma can be considered in patients with unresectable disease after new adjuvant chemoradiation in centers with a specific protocol. Regarding the intrahepatic cholangiocarcinoma, the treatment of choice is liver resection, and transplantation is reserved for unresectable cases and should only be performed under strict clinical protocols in cirrhotic. And in non-cirrhotic, the use of neoadjuvant therapies aiming to convert unresectable patients might be preferable to liver transplantation under the light of organ scarcity. However, it would be fair to offer liver transplantation for patients who remained unresectable. For mixed hepatocholangiocarcinoma, these tumors carry a poor prognosis, especially in case of the dominant cholangiocarcinoma component, and currently is not an established indication for liver transplantation. For colorectal carcinoma, based on FUNG clinical score, metabolic tumor volume, and Oslo score can be used for selection criteria to obtain 5-year overall survival comparable to other indications for liver transplantation. So in conclusion, if we try to expand the criteria for liver transplantation, we should take into account tumor biology, response to therapy, time from diagnosis to transplantation, and response to neoadjuvant therapy in case of cholangiocarcinoma. Till now, identifying aggressive tumor pre-transplant remains difficult with current imaging and tissue sampling technique. And thank you so much.
Thank you, Professor Asma, for this nice presentation. And we will postpone the discussion till the end of the session.
We all fear infections in transplant recipients as they may progress severely. And as we are now suffering from the COVID pandemic, which is associated with considerable morbidity and mortality, the vaccine becomes mandatory in these patients. When should the COVID vaccine be given post-transplant? How many doses should the patients receive? And should the patients on the waiting list be vaccinated? These questions will be answered in the next talk. May I present Professor Khaled Amer to discuss this issue. Professor Khaled Amer is a professor at the National Liver Institute, Menifee University.
thanks, Mr. Chairman. COVID-19 vaccine post-liver transplantation. طبعا الصورة دي كلنا عشناها أكتر من مرة. There are several COVID-19 vaccines validated for use by WHO. The first mass vaccination program started in early December 2020, and the number of vaccination doses administered is updated on a daily basis on the COVID-19 dashboard. COVID-19 vaccines provide strong protection against serious illness, hospitalization, and death. COVID-19 vaccines are highly effective, but some people will still infected by COVID-19 after vaccination. There are three main approaches to making a vaccine, either by using the whole virus, or parts that trigger the immune system, or just use the genetic material. This figure shows the vaccine platform designed to train our immune system. Types of vaccine platforms, there are two categories of COVID-19 vaccines, either component viral vaccines or whole viral vaccines. Component viral vaccines include protein subunit, which contain isolated and purified viral proteins. Virus-like particles contain viral proteins that mimic the structure of the virus, but no genetic material. DNA-based and RNA-based contains viral genetic material such as messenger RNA, which provide the instructions for making viral proteins. Non-replicated viral vector contains the viral genetic material packaged inside another harmless virus that cannot copy itself. Replicating a viral vector, which contains viral genetic material packaged inside another harmless virus that can copy itself. The whole virus vaccines, including inactivated viral vaccines, contain copies of the virus that have been killed, or live attenuated vaccines contain copies of the virus that have been weakened. Viral vector vaccines for COVID-19, like AstraZeneca vaccines. AstraZeneca uses this technology to protect against COVID-19. This type of vaccine uses an unrelated harmless virus. Genetic vaccines for COVID-19, like Moderna and the Pfizer vaccines, uses this type of technology to train the immune system. The vaccine contains a segment of genetic material of the SARS-CoV-2 virus, which causes COVID-19. The genetic material, RNA, in the case of Moderna and the Pfizer vaccine, code for a specific viral protein. Inactivated vaccines for COVID-19, this type of vaccines contains the killed SARS-CoV-2 virus, which recognized by the immune system to trigger a response without causing COVID-19 illness. Attenuated vaccines for COVID-19, this type of vaccine contains the weakened SARS-CoV-2 virus, which is recognized by the immune system to trigger a response without causing COVID-19 illness. Protein vaccines for COVID-19, this type of vaccine contains the proteins from the SARS-CoV-2 virus, which are recognized by the immune system to trigger response. As of 12 January 2022, the following vaccines have been obtained. Pfizer vaccines started to use at 31 December 2020. AstraZeneca vaccines from 16 February 2021. Johnson & Johnson, 12 March 2021. Moderna, 30 April 2021. Sinopharm from 7 May 221. Sinovac, 1 June 221. Bharat Biotechnic vaccine, 3 November 221. Covovax vaccine, 17 December 221. And the last one, Novaxovid vaccine, 20 December 221. Many societies have recommended vaccination of organ transplant recipients. Recent studies reported that only 17% of organ transplant recipients developed detectable antibodies to the SARS-CoV-2 spike protein after first dose of messenger RNA. And this, detecting that one dose is not effective for these patients. A weak immune response to 2 doses of vaccine against the severe acute COVID-19 has been observed in recipients of solid organ transplants. Severe cases of COVID-19 have also been reported in transplant recipients who had received 2 doses of vaccines. So 2 doses also not efficient. Research has shown that many organ transplant recipients do not develop antibodies against the COVID-19 after receiving a primary COVID-19 vaccine regimen. Even after receiving a 3rd dose of COVID-19 messenger RNA vaccines, many transplant recipients still fail to produce an antibody response. So also 3 doses also not efficient. We have several questions need answer. The first one, when the vaccine post-transplant should be given? نبدأ امتى ندي الفاكسين؟ New transplant recipients should delay receiving a COVID-19 vaccine. For patients with kidney transplant, we wait 3 months after transplantation. And another all organ recipients like liver transplants should wait for 1 month after their transplant. This delay in vaccination is necessary to give the immune system enough time after transplant to recover to a level where the vaccine is more likely to be effective. The second question, why should transplant patient get a 4th dose from COVID-19 vaccine? والسؤال ده امبارح كان سأله الدكتور سيد عبد العال. A 4th vaccine dose will help give transplant patient the best level of protection. Here is why vaccination will reduce the probability to have severe disease and require hospitalization or care in the ICU. The immunosuppressive therapy make it difficult to attain a protective immune response after 1, 2, or even 3 vaccine doses. Each additional dose will help immune system response to infection. امتى ندي الفاكسينز؟ Timing for vaccine doses. بالنسبة لفايزر فاكسين احنا قلنا ان هنبدأ الفاكسين بالنسبة للعيان بتاع الليفر ترانسبلانتيشن بعد شهر من الترانسبلانت. السكند دوز at least 21 days after first dose, and the 3rd dose at least 28 days after second dose, and the 4th dose at least 3 months after the 3rd dose. بالنسبة لموديرنا vaccine, second dose at least 28 days after first dose, 3rd dose at least 28 days after second dose, and the 4th dose at least 3 months after 3rd dose. بالنسبة للي هياخد جونسون اند جونسون هو معروف ان هو بيتاخد جرعة واحدة بس، عشان كده السكند دوز هتبقى من another vaccine messenger RNA vaccine like Pfizer or Moderna at least 28 days after the first dose, and the 3rd dose اللي هي البوستر دوز with messenger RNA vaccine at least 2 months later. ايه اللي ممكن يحصل لو العيان اخذ فاكسين من شركة تانية غير الشركة اللي اخذ منها في الاول على اعتبار انه ممكن يكون مش موجود منه جرعات تانية؟ In general, for the messenger RNA vaccines like Pfizer or Moderna, try to stick with the same for the first 3 doses. If cannot, it is okay to get whatever is available. The booster doses can follow a mix and match approach of using either available vaccine even if it differs from the first 3 doses. يجي السؤال اللي بعد كده. How many doses will it take? For transplant patients who do not respond to their primary vaccine series, an increasing number will be able to make their own protective antibody response after a 3rd and then 4th dose. In the future, the need for booster dose may be guided by the emergence of other variants and a more individualized assessment of response of the COVID vaccine. The last question, should patients waiting before transplant be vaccinated? The answer is yes. Vaccination is more effective when given before transplant. Ideally, vaccination at least 2 weeks before transplant to give the immune system time to respond effectively. Transplant may be delayed or canceled if the patient develops COVID, just as the case should be with any other active infection. And this is the last slide, and many thanks for your listening.
Thank you, Professor Khaled, for answering all these questions in an elegant presentation.
I'm lucky enough to present two of my colleagues. The first is Dr. Mohammed Al-Tabakh, the coordinator of our transplant program for over 10 years, and who joined the program since its very beginning in 2003, the re-initiation of the program, I mean. For unforeseen circumstances, he could not join us today. And the second colleague is Dr. Zahra Al-Khatib. She is a distinguished member of our transplant program team, and she was one of our flying birds to UK. She will present an unusual complication after liver transplant. Thank you.
Thanks, Dr. Wael, for this nice introduction. Today we'll present an unusual complication in actually unusual patient. So let's start over. Our patient is a male patient, 38 years old, diagnosed as hepatitis C positive in 2015, received direct acting antiviral, and kept sustained virological response till this moment. 2019, he had a slurred speech, weakness of both lower limbs, more than upper limbs with progressive spasticity, and finally diagnosed as spastic quadriparesis with no obvious etiology, with poor response to L-DOPA with no improvement in neurological condition. 2021, he had a recurrent attack of hepatic encephalopathy and ascites with more deterioration of his neurological condition, which leads to poor quality of life, so he was referred to us for liver transplantation. He is hypertensive on beta blocker with irrelevant family history. When we check his hepatic side of a lab, he was male 19 with a negative autoimmune marker, hepatitis C positive, as we have previously mentioned, and he is negative PCR for CMB, normal electrolyte, and just only low level of cerebrospasmin with normal iron profile and slightly elevated blood ammonia. He had a liver cirrhosis sensitive with no focal lesion with a mild ascites. So we checked his neurological condition. He has a peripheral nerve conduction is normal, and when we checked his simultaneous CSF and serum analysis, it was a negative for oligoclonal brandis, which is common with CNS lupus or CNS tumor infection. So MRI brain was ordered for him. He has a convolutional changes that doesn't match his age, with a brain atrophy and, interestingly, bilateral manganese deposition in his basal ganglia. So we doubly checked his blood manganese level, and it was another surprise. It was slightly elevated, maybe double upper limit normal with a normal urinary one. So we have a challenge. Shall we transplant him or no? So we have two scenarios. If this patient has a brain and the hepatic axis connected together, so due to either hyperammonia or hypermagnesemia, so when we break this axis down, this patient will recover. But if we have two different entities, hepatic and neurological condition, and we transplant the patient, he will have a good liver, but still or more deteriorating neurological condition. But finally, we decided to transplant him in April 21. From a living donor, he received the barzolvolimab as induction. During the first 3 days, he was vitally stable, conscious with no complication, but on the fourth day, he had aphasia, hallucination, and delirium with myoclonic convulsion. That's why we started anti-epileptics. On day 5, he became feverish, desaturated, with more and more deterioration of his neurological condition. Checking his examination, he was hypertensive, as we know, with high fever, with desaturation, with intact reflexes, and no neck rigidity, which excludes CNS infection. Checking his lab, he similar to the picture as we see in COVID infection, like an lymphopenia and the dimer, high elevated dimer with CRP elevated. So we go with the flow, and made CT chest with him. It was, there was a multiple bilateral ground glass patches as diagnosed as a Corad 5 with bilateral effusion. But his PCR done twicely and it was negative. So we concluded that maybe it is like a similar to COVID infection. For the neurological condition, we did MRI with diffusion for him, and it was showing a transient sign of cytotoxic lesion in his corpus callosum. Maybe drug-induced is metabolic, we didn't know. But we suspected to have a lichen cytokine surge in his blood, so interleukin 6 was ordered, and it was marvelously increased in his blood. So we started to increase his steroid as a bolus from his line steroid to 1.2 milligram per kilogram. On day 7, meaning after 2 days from his fever or neurological condition and starting his steroid, he became a conscious, cooperative, and vitally stable with a normal oxygen saturation, no convulsion, no aphasia, with improvement of his ongoing neurological symptoms. CT chest, there is a ghost which had gone marked regression of his ground glass appearance and total resolution of his left pleural effusion. So what is on our differential? It may be drug-induced neurotoxicity, post-transplants, maybe deteriorating from pre-transplant hepatic myelopathy or cytokine surge. Just going rapidly, what is hypermagnesemia, so we can conclude on what happened later on to the patient. Hypermagnesemia can be due to overexposure, due to like working in the mines, or chronic TBN or liver cirrhosis, maybe due to genetic deposition. So if it have genetic deposition, so maybe autosomal recessive. The patient has extrapyramidal manifestation, polycythemia, and hepatic dysfunction, leading to cirrhosis, maybe a late onset or early onset as like our patient. The treatment is just a chelating agent. The patient will respond and he recover from his neurological disorder. So shall we go to the post-transplant condition? What is a cytotoxic lesion? It is the lesion that appears in MRI sorry, as hypointense in T1, hyperintense in T2, with no enhancement with contrast. The causes may be due secondary to drug therapy, malignancy, infection like the coronavirus, or subarachnoid hemorrhage, or metabolic disorder, or trauma. Maybe liver transplant itself, or alcohol, or hyponatremia can cause it. So lead to myelinotoxic factors that release cytokines and lead finally to cytotoxic edema. After 11 months from transplantation, the patient became normal. He had a normal graft, normal liver profile, no slurred speech, improvement of his spasticity. He finally walking with a minimal assistance. Next month will be our 19th anniversary for liver transplant unit, so I will take a chance to thank our founders for this unit and our coordinator, Dr. Mohammed Tabakh and Dr. Mohammed Abbasi, and our great team for the support and giving back this picture for the liver transplantation. Thank you. This is another team. Yeah. Yeah.
Now it's a great pleasure to me to introduce Professor Hussam Siliman, the Professor of Hepatobiliary Surgery at the National Liver Institute. Dr. Hussam was among the first team who started liver transplantation program at the National Liver Institute. He was also the coordinator for transplantation program for long time. Today he will share us his experience about the small for size syndrome in Egyptian patients.
Thank you, my dear colleagues and friends, Dr. Nagla, and also يعني مجموعة من أصدقاء وعمر طويل ومشاركة على مدى سنين طويلة. يعني أنا برضو في البداية بس أحب إن إحنا كلمة أنا هقولها بالعربي. If we have some of our colleagues who are from foreigners, it's 30 years now since we have liver transplantation in Egypt. We have passed 3 decades. for the first successful transplantation. This transplantation was done in Minofia, outside Cairo, by pure Egyptian hands with very low technical capabilities at that time. So nothing is impossible actually for us as Egyptians and مش منايفة يعني بس يعني as graduates of the National Liver Institute. Because most of them were not Monocytes. Of course, all of us know that liver transplantation is the end stage of liver disease. It was initially introduced for children and then expanded to the adults. In our selection in the liver transplant unit and for thinking with patients, we always try to have a big graft for this recipient. It usually maybe 1% looks satisfactory to us, to all of us. Smaller than GRWR than 1 is usually potentially small grafts. And this actually puts that the majority of our grafts are potentially small. Later in the literature, the cutoff value was a little bit decreased to 0.8. So if the graft's function cannot meet the demands of the patient, then the small for size syndrome appears, which is characterized by prolonged cholestasis and intractable ascites. And usually the outcome is not so good. But is it really a matter of graft volume? Is it really a graft volume size itself, or there are many other issues in the... Actually, there are many issues. The graft mass itself, whether it is like a GRWR, the state of this graft, the age of the donor, the parenchyma of the liver itself, also the metabolic demands of the recipients, and the early injuries that face this graft by venous outflow, inflow, hyperperfusion, or rejections. So when we try to change our concepts and try to make modifications, we always try to search. We may search in the literature books. So if we found something inside the boxes, then we are doing modification. And if we are doing something new, then it is an innovation. And actually, there are very few innovations available now for the management solutions of small for size, and there are many modifications that has to be done, or can be done for those patients. The first successful small graft was 20 years ago, where in a cadaveric transplant they discarded the right lobe for occurrence of a hematoma, and they used a left lobe graft, which was 0.61. And I remind my colleagues that the first case in our study was quite long. I will speak about it later. But also, what was interesting is this patient that it has some kind of a modulation of the portal flow. He had a mesocaval shunt, and the surgeon, Poilot, everybody know him, did ligation of the superior mesenteric vein. So this introduced the concept of modulation of the portal flow. The outcome was very successful, so this initiated many studies. And if we review the literature, we will find that there are very small grafts that has been transplanted successfully, up to 0.34, 0.6 and 0.45 and 0.59. In our experience in the Liver Institute, the first small graft was it was 2008. It was a 0.6 graft. It was done successfully with splenectomy. And the smallest graft so ever transplanted successfully in Egypt occurred with us in our center in the National Hepatology Institute in Cairo, where we intraoperatively decided to change the decision from a right loop to a left loop graft who looked satisfactory volume, but unfortunately the graft was very small. The GRWR was 0.47, and as all we know, we worked there with a routine temporal portocaval shunt, and we did for him splenectomy, and his post-operative course was quite excellent, and was just similar to any other case. And now the transplanting small graft is not something that is, let's say, it's a routine practice. In our newest center, we are working into 5 out of 7 cases had a small graft, and we lost only one adult patient who had a right lobe graft and who had COVID infection 2 weeks post-transplant. So small grafts can be used effectively in whatever the cause is, with special precautions. So large grafts can be replaced by small grafts with optimum function. This is done primarily to save for the sake of donor safety. The first, I will speak rapidly about the practical solutions we use. First, we use young donors. The smallest graft I spoke about was from a donor who was 18 years. With no steatosis or a very, very minimal steatosis with a calculation of correction of the graft volume. So the donor age, young donor age also is one of our papers published by our colleague Mahmoud Mashat, who is working in Kyoto. In the Kyoto experience, the young donor age is 45 for the Japanese. But our data in our Egyptian, so we should consider young donors 25, less than 25 to tolerate well small grafts. Recipients can have better graft quality. The second issue is optimization of the outflow. By studying more and more details about the segmental venous drainage and using accurate volumetric calculations with the newer advanced modalities. This is another one of the examples from our institute. Graft with V5 11.7%. This has to be constructed, and we reconstructed with the synthetic grafts. And in this case, this is a multiple hepatic veins in a small graft who had V5 and multiple V8, so we used a natural vein graft for his outflow obstruction. The third solution is portal flow modulation. We all know that the largest amount of flow that can go to the liver can lead to injury, immediate injury, and so we have to measure the portal flow either by pressure, measuring the pressure, or the flow volume. And the solution are splenic artery embolization, splenic artery ligation, or splenectomy. Splenectomy is most effective, and this has been validated by the Kyoto group, and it's very, the calculation of the graft volume, splenic volume in relation to graft volume with a GSVR less than 0.7 as a cutoff value. When can we do splenectomy? Usually we take the decision in a preoperative way by calculating the GSVR volume, and also by intraoperative by final measuring the portal pressure. And this is one of the examples. If we see the data here, the GRWR, estimated GRWR is a 1.2. But the spleen volume was quite very huge, and in the relation to the graft, we removed this spleen, and this patient outcome became much more better. This is how we measure it using a pediatric CVB catheter inside the mesenteric branch with continuous monitoring and decision making. The fourth solution is the portosystemic shunt, significant shunts. The significant shunts has to be ligated and has to be demonstrated clearly, preoperatively, and then we take a decision for ligation or not. But usually we routinely ligate all the shunts. And this is our pressure measurement. There is the fifth and the last solutions. I know you are all fed up. So the routine shunting. We have to follow a routine technique. The routine temporary porticeval shunts makes the operation more stable, more hemodynamically without the use of supports. So injury can be minimized to the graft. In conclusion, there are many challenges actually for the living donor, but these issues has to be studied more details in the Egyptian patients because our patients are quite different than the patients who are without bilharziasis and type 4 virus C. However, donor safety remains of first priority, and to all of us, the rewarding point in the field of liver transplantation is seeing the patient quite well, like the patient we have seen before. And also, leadership is very important to have good success of programs. Thank you, and I hope I'm not too much. Thank you.
Thank you, Dr. Hussam, for this elegant presentation. Thank you.
Any questions? Okay, due to the delay in the program, if anybody has any questions, we can discuss privately. I'd like to thank all the speakers and all the chairpersons, and we conclude this session and invite the chairpersons of the next session. Professor Hussein Hiaqaisha, Professor Ashraf Amin.
بسم الله الرحمن الرحيم. Final session about sonography. Professor Hussein Okasha will introduce our next speaker.
بسم الله الرحمن الرحيم. I have the pleasure and honor to introduce Professor Peter Bellman, a very well-known figure in endoscopy and endoscopic ultrasound. He is a professor at Department of Clinical Medicine, professor of endoscopy in Copenhagen University, Denmark. He will talk us today about EUS guided biopsy from the past to the future. Please.
Thank you for your kind invitation. I'm grateful to be here for the second time at your wonderful conference. And thank you for the hospitality, which has been extremely good. So it's my pleasure to talk about something that has been a great part of my clinical life, which is US-guided biopsy. And I'm professor at Herlev Hospital in Copenhagen, Denmark. So these are my disclosures. So the aim of my talk today is first a historic background seen from a personal perspective on needle developments of US guided biopsy, and summary of results from key needle studies in gastroenterology in particular. Future direction, also looking a little into fine needle aspiration and core needle biopsy called FNB. So when I started my interest in the US, I visited at that time the absolute pioneer, which was Loctio in Amsterdam. That was in 1985, many years ago. At that time, it was only mechanical rotating transducers that were available. But they gave good images of the GI tract. At that time also, people really thought that if a lymph node was round, sharp demarcated, echopore, and a size more than 1 centimeter, it was malignant. We know now today this is not true. A lot of false positive diagnoses. But again, depending on the severity of the cancer disease. I started with a curved linear array endoscope in 1989 at a time where there was only 2 publications on US with linear endoscope. Both of these publications were from the group of DiMagno in the US. The first publication was in animal models, and the second was in humans. And the conclusion was, this is not for human use. It's too difficult. The anatomy is impossible to differentiate. And then I began with a linear transducer. I published my first publication in 118 patients in 1991. This endoscope didn't have a biopsy channel, but we were able to persuade Hitachi, at that time it was Hitachi in collaboration with Pentax, that they should create an instrument with a biopsy channel. So it came in 1991, and immediately at that time we were able to do an US-guided fine needle aspiration biopsy of a pancreatic lesion. This was published in 1992 in GI Endoscopy. So the first time this was performed. I began together with companies to develop needles for US-guided biopsy, and the first needle assembly was created by my group together with GIP, which is today Mediglobe, and was called the Hanke-Willmann needle. Hanke was my mentor. So, as you can see here, different needles. And my thesis, which I defended in 1998, was basically a proof that if you could see by imaging and say this is cancer or not cancer, you were not correct in all cases. In many cases you were incorrect. But if you did a biopsy from the same lesion, you were always correct if the biopsy showed cancer. So today there are many needles on the market, and all these needles are made based on the same construction that we came up with in our construction was finished in about 1993, 1994. So, but at that time, we didn't realize what the indications were. In the beginning, we thought submucosal tumors maybe, that could be an indication. But to stick the needle through the GI tract, that was completely new. And actually, people told me that to stick a needle through the esophagus into the mediastinum is dangerous. So we actually collected our material in Denmark with material from Moritz Wiertzemer in the US, with Marc Giovannini in France, and with Kenneth Chang also in the US. And this publication, which was published in Gastroenterology, was for many years the biggest collection of patients. And it gave us the let's say, impression of where the indications were with EUS-guided fine needle aspiration. Sensitivity was high when it was solid lesions. However, in submucosal lesions, in lesions of the gut wall itself, lower indications. In cystic, even lower sensitivity. Sorry. So we know today that the indications are staging of upper GI cancer, staging of lung cancer, primary diagnosis of mediastinal lesions, lymph nodes, submucosal tumors, pancreas and biliary tract lesions, adrenals, and the sensitivity lies in the range of 60 to 95%, but for cystic lesions lower, 40 to 50%. I was also deeply involved in development of EBUS tBNA, and I was, together with Olympus and one of our thoracic surgeons, deeply involved in the let's say, testing and development of the needle device for this method. Our first publication, which was preliminary experience with the new method of endoscopic transbronchial real-time ultrasound-guided biopsy for diagnosis of mediastinal and hilar lesions, was published in 2003. Our group was also the first to suggest that mediastinal staging for lung cancer should be performed both transesophageal and transbronchial, published in 2005. I'm actually proud to say that I was part of the guideline written between the ESGE, the ERS, which is the European Respiratory Society, and the European Thoracic Society, stating that the gold standard in Europe for mediastinal staging in lung cancer is endosonography. Endosonography before mediastinoscopy. We know also about complications of EUS-FNA, which are low. And the morbidity are most, and events are mostly associated with mild to moderate severity. We also know that there are a few needle tract seedings, which was of concern, but these are all the case studies that have been published during more than 30 years. And if you can notice that most of the needle tract seedings were performed with puncture through the stomach wall into a lesion in the pancreas. So in a patient potentially resectable, I think you should think twice before you do a biopsy through the gastric wall. But the sensitivity, this is a systematic review and meta-analysis available, sensitivity for pancreatic cancer diagnosis is around 90%. for many years, we were told by our surgical colleagues that you're not allowed to do FNA if the patient is going to be resected. But we know now that this is not true. This is a series of more than 2,000 patients which have either been biopsied prior to Wobble procedure or no biopsy, and there is no difference in survival between these two groups. So we can still now argue that we can do a biopsy even though the patients are undergoing surgery. Lots of publications, and I've been part of many of these publications to increase the diagnostic yield of EOS-guided fine needle aspiration. And we have been doing randomized study between with or without stylet, with or without suction, with or without rapid on-site cytology, slow pull techniques and all these things. And basically it doesn't really matter what you do, whether you do suction or whether you don't. But what I would like you to notice is that the sensitivity is similar regardless of needle size, but bigger needle take bigger bites. So if you want histology, then you should go for a bigger needle. Today there are new needle designs called FNB needles on the market. Please notice that the shark core, the acquire, and the top gain needle are the ones that you should choose if you want to do an FNB needle for an optimum biopsy. I regard these as not third generation, but second generation, which is the reverse beveled needles. And these needles are demonstrated not to, at least to be inferior to the crown cut needle types. We know from meta-analysis that the pro-core needle and standard needles were comparable in terms of diagnostic accuracy. And there's no difference in histological course between a standard FNA needle and a pro-core needle. They come up with a study with 20 gauge FNB needle, the pro-core, versus a 25 gauge needle. But you could say beforehand which one would be the winner. Histological course, the bigger needle, the better histological course. So not a surprise that the 20 gauge took better histology than a 25 gauge smaller needle. So coming to crown cut needles, which are the shark core, the acquire, and the top gain needle. As you can see, these are crown cut needles, front cut needles. One of the first publications demonstrated a high diagnostic yield in 30 patients. And for the first time, the size of the histological core was measured, 2.9 millimeter. It has never been done before this study, size of it. Now we know a 20 gauge pro-core needle, which is a big needle, compared to a 22 gauge acquire needle, a small needle but front cut, take better histology course than the 20 gauge, the bigger needle. Double the size of the histological sample. So now it's not true anymore that bigger needle take bigger bites. Yes, if it's a crown cut needle, the bigger the needle, the bigger the histology core again. There are randomized studies between the acquire needle and the shark core needle. There's no difference in sensitivity and in the also yield of histology. We know also that FNB needles are superior to EUS FNA if it goes for submucosal lesions, GIST lesions of the GI tract. So today, FNB needles should be preferred for submucosal tumors. We also know for autoimmune pancreatitis, no doubt it should be a front cut needle that should be used for this. As you can see, this is compared to the side bevel needle, the Procor needle, and it demonstrated that 78% in the front cutting group and only 45% in the forward bevel group were diagnosed with level 1 and 2 autoimmune pancreatitis. So why should we be using FNB needles, and what is the difference from FNA? We already know now that it takes significantly bigger bites, bigger cores. But there is a technical difference, and there is also a difference in specimen preparation. I call the FNB method the stabbing method, because it's not as sharp as an FNA needle. So you really have to stab the needle into the lesion, as you can see on this image. So to get the needle in and get it in and out the lesion, you really have to make a forceful stabbing method like this. Pathology preparation. Again, you know, it's different. FNA needles is cytology and smear cytology, as you can see on the left slide. But FNB needle is histology, and histology is not smeared. Histology should be placed in formalin and prepared as standard histology. Preserved tissue versus single cells, single clusters of cells. So our suggestions to the indications of EUS FNB is, if you want to differentiate between two tumors, if you want to diagnose GIST, if you have a suspicion of lymphoma, neuroendocrine tumors, autoimmune pancreatitis, sarcoidosis, sarcomas, and where more cellular material is needed for molecular analysis, pancreatic cancer, personalized medicine, and when good material for immunohistochemical analysis is warranted. So if you are interested in EUS FNB, FNA, may I place your attention toward this upcoming webinar, March 31. Tissue is the issue. We are going to discuss the indications and all these things that I have only touched very loosely upon. Endoscopyonair.com. You need to register. Registration is free. So, what about cystic pancreatic lesion? Is there a diagnostic dilemma with EUS-guided biopsy? You know, the results are not very good. Cytology sensitivity is only about 50%. Even CIA content is higher in the diagnosis of mucinous cyst. So we need to find new ways of diagnosis. We did a prospective study in more than 100 patients with microbiopsy forceps. Via a 19-gauge needle, we are able to insert the biopsy forceps into the 19-gauge needle and grab a sample, as you can see the tenting effect, a sample from the cyst wall. And our results demonstrated that to discriminate between mucinous and non-mucinous lesions, the sensitivity with our microbiopsy was 73% versus cytology only 30%. And even the specific diagnosis, is it a pancreaticobiliary, is it a gastric type, is it a so and so on, can be performed with this microbiopsy. So this might be a way to go forward. What about future direction for EUS-guided biopsy? EUS imaging and biopsy is closely linked. Needles, new needle designs maybe, and diagnostic, genomics, transcriptomics, proteomics, organoids, and tailored therapy. I will touch upon that very closely. So first of all, I think we will see new transducer technologies. This is a single-use plug-on technology already on the market. And of course this may affect on what we are going to do in the future. Artificial intelligence is coming also within EUS to direct us to the right lesion to puncture, and image fusion as well. New needle types. This is one new needle type, which is a Mengini type biopsy needle with a rolling method, demonstrating that it takes bigger bites. New needle designs. Future directions for genomics, transcriptomics, proteomics. We know already that the diagnostic yield of EUS-FNA increase if you use molecular analysis. So half of inconclusive EUS-FNAs carry oncogenic mutations and can be diagnosed by genetic molecular analysis. We have now also a randomized study between EUS-FNA and EUS-FNB showing that histological core tissue and adequate nucleic acid yield is much better with a crown cut needle design than with an FNA needle. So for again, we need, if we need molecular analysis, it's FNB needle. Our group is now growing organoids, pancreatic organoids, where we do FNB and directly go to the lab and spread it out. We have great success in culturing these organoids, and we have also begun to do pharmacotyping of these organoids. And I think this is part of the future, and for that we need good histology. To do tailored therapy for several of the tumors that we are involved in, and in particular pancreatic cancer, which has a dismal prognosis. So, tissue is the issue. EUS-guided FNA has undergone 31 years of evaluation. A wide range of established indications of EUS-FNA exist, including staging as well as primary diagnosis of a variety of lesions. Standard EUS-FNA needles are not inferior to a reverse bevel needle when it comes to sensitivity and harvesting of core tissue for histology. But new crown-cut core needles improve significantly histological tissue harvesting from solid lesions. An unexploited potential for obtaining material for molecular analysis and harvesting of cells for growing of organoids exists. EUS-guided biopsy may in the future become an important method in tailored oncological therapy. Thank you for your attention. Yeah.
Regarding Murray microforceps, you prefer to take biopsy from the mural nodule itself or from the cyst wall? I think the mural nodule will be more informative but carries a high probability of bleeding. I tried it and there is bleeding. Although the bleeding in always most cases are controlled because it occurred in a confined space. What is your practice in this situation?
We always try to get to the mural nodule. Sometimes it's not possible because the direction of the needle is not where you want it. And for those cases, we have to go for the wall. And you're right, we have seen also some bleedings inside. And what you see is sometimes spurting vessels, and your pulse goes up, but then when it fills up, it goes slower, and it's self-controlling. We have never had any severe problems.
Any serious problem. My comment, we did a large-scale study about comparing FNA and FNB, and suction. There is no significant difference between these. The significant difference is the professionality and professionality of the cytopathologist. The cytopathologist, the local cytopathologist is totally different from the central cytopathologist. So I hope that in your practice the cytopathologist is clever. This is a very crucial, very crucial incident.
I agree, and you know, this has actually limited the, I would say, the spread of this method, because I mean, many pathologists prefer histology, but my take-home message now is it's excellent if you have an excellent cytopathologist, but it may be, let's say, preferable now to take FNB needles with histology and prepare this as histology, because I think it will be more, let's say, more people can diagnose.
Yes, much more easier in interpretation.
Yes.
Thank you very much, Professor Velman. When should I have a concern for tract seeding in AOS-guided biopsy in pancreatic lesions?
Yeah, as I told you, in a patient that is, I mean, a patient that is operable, where surgery is the next step, I would not go for a biopsy transgastric. But if the patient is resectable and the lesion is in the head of the pancreas, I do a biopsy of the tumor anyway, because in many cases they will refer the patient again also after surgery for oncological treatment, neoadjuvant treatment, things like that, and most of the patients will need a biopsy. So, and there's no difference between those that are undergoing surgery, all that are undergoing surgery, those that have undergone biopsy versus those who have not. No mortality, no, let's say, survival difference between these two groups.
Even from those tumors in the pancreatic body and tail, even the biopsy from the stomach, your practice is doing FNA, even in the body and tail. You also do a biopsy from lesions in the pancreatic body and tail from the stomach also, if it is resectable.
If it is not resectable, I will. If it is, I mean, if the patient is deemed not resectable, I will do a biopsy.
But if it is resectable?
Yes.
You do
not
also?
Not resectable.
But
I mean,
if resectable?
If the patient is a fully resectable patient, I will not go for a biopsy transgastric.
Okay.
Not transgastric, but I will do that transduodenal.
Yeah.
I have no concern transduodenal.
Whether resectable or not, yes. This is also our practice in Egypt. Yes. Okay. Thank you very much.
Thank you.
Many thanks, Professor Velman, for this nice lecture. We will move to next speaker, Professor Adan from Croatia, and speaking about how US URCP are upgradable.
Hello.
Hello.
Hi. Do you hear me?
Yes, we hear you well.
Yeah. Okay.
Welcome.
I share my presentation or. Okay, is it good for you?
Yes, very nice.
Okay, thank you very much for inviting me again. As Professor Peter Willman says, you invited me again, and I assume that my lecture last year was good, so I'm happy now to be again with you. And also, I have to say hello to Peter Willman and congratulations for the inspiring lecture, as always, as you can do. And I would like to remind you on our cruising, I don't know, maybe 15 years ago on Ohrid Lake in Macedonia. A few months after our cruising, this ship sank in a storm. So I'm happy that we are both here again. So, and we can speak about nice things about endoscopic ultrasound, and I will talk about the nice friendship between the endoscopic ultrasound and ERCP, and those are the two complementary techniques, and they are dedicated for the biliary and pancreatic diseases. And in this lecture, I would like to clarify the connection between these two procedures with the idea to put the focus on the categorization of the relationship between endoscopic ultrasound and the ERCP based on whether endoscopic ultrasound indicates, complements, facilitates, or replace the ERCP. ERCP was inaugurated over the 50 years ago and was a revolutionary and primary procedure for diagnostics in the pancreatobiliary tract. And during these 70s, it experienced a major expansion. But in the 80s and the 90s, we are facing a robust growth in a number of diagnostic and total amount of the ERCPs to middle 90s. In the middle 90s, we have some kind of the diversion, and that diversion means that was driven by the more than 75 decrease in diagnostic ERCP and increase in a therapeutic ERCP. Therapeutic ERCP is burdened by the more complications, so we have to think about that, and it is wise to measure 3 times before you cut once. For the measuring, I mean to have complement tests to do that. And one wise sentence is, well, I think the avoidance of unnecessary ERCP is the best way to reduce the number of complications. And nowadays, we have confirmatory tests for the ERCP is a MRCP, and MRCP is a nice contribution to our diagnostics, especially because it lower the cases that needs ERCP, and it's predominantly we use it, and it helps us in cholecystolithiasis, bile duct lithiasis, and also when we are in doubt about the rupture of the pancreatic duct, or if there are connections, especially with the pancreatic duct in the IPMN. On the other hand, the endoscopic ultrasound was inaugurated, as Professor Willman says, in the 80s, and in the early 90s, Henke and Willman inaugurated the pioneers, and from them we start to have expansion in the field of in the field of upgrading these method, especially endoscopic ultrasound, and also as well, and also the ERCP. So they have some common complementary fields like choledopolitiasis, pancreaticobiliary neoplasms for the biopsies, fine needle biopsy, the ductal drainages when the ERCP fails in 10% of the cases, altered anatomy, and also with the amplectomy, and also finally on the fluid drainage after wounds and stuff like that. So we came to this categorization. What I was trying to talk. That means that we have some things that we have to think about. That the risk of adverse events growing up with the upgrading of the difficulty, and also that stage. On the stage 1, we only confirms the indication for ERCP. In the second stage, endoscopic ultrasound complements ERCP by providing the important clinical data or basic therapy. The role of endoscopic ultrasound in these first 2 stages is basically diagnostic, and that is why it is considered that they are within the reach of the second-level hospitals. If in here we include the fine needle aspiration, celiac plexus neurolysis, and also simplex collection drainages. When we to this grade 3, in grade 3, that stage involves the step forward in difficulty with the technique, and in that technique we can replace the ERCP by the means of the endoscopic ultrasound and puncture the bile duct, and we can have a picture of the bile ducts, and also in altered anatomy we have EDGE when we can go with the endoscopic ultrasound from the remnant from the stomach pouch with a lumen opposing metal stent at least 2 centimeters in diameter, that we can go in the remnant of the stomach, and we can prepare the endoscopic retrograde endoscopic cholangiopancreatography. When we compare that in this nice case of and this paper from the KEDIA, they compare the laparoscopic assisted ERCP, the EDGE, and in the means of technical success. Success in achieving therapeutic ERCP, and they are comparable, but they have significant difference in procedure time. It's 73 versus 184 for the EDGE, and significantly hospital stay is reduced after EDGE procedure. So when we finally comes to the fourth stage, that includes the techniques in which endoscopic ultrasound provides the ability to replace ERCP. We come to the field of the surgery and the notes, and that is very, very thrilling, and something that we have to do, and that needs most experienced doctor to do that. Besides that, we have a lot of other threats. What I was trying to talk about that. We have also issue on transmission of the multi-drug resistant organisms, and especially in the duodenoscopes. The duodenoscopes are designed that they have a rubber cap or a plastic cap that avoids the tissue injury, and inside of these cap, especially in the United States, they found a significant problem of poor disinfection. So ESG, ESGINA, and our society Society of Gastroenterology, we issued the quality control parameters and for disinfection, sterilization, and the storage of the instrument. So we gave the eye signal to the innovation and industry to help us. So the first thing that they do, that they prepare the disposable tips for the ERCP, so we can open them, flush them, and that means that that it's a very, very good initial. But also it labored the new disposable endoscopes, duodenoscopes, which I think that we can talk about that. They are very expensive at the moment, but there are a lot of issues about that because there is some cost us for the reusable instruments, and there are hidden costs also for the sterilization, for the detergents, for the learning curve, for the sterilization, and that also I think it's very important. There is a ecological environmental issue that probably reprocessing of these instruments in the future will be very, very important, what I say. So the important thing is that we trigger the domino effect, and we are thinking about that. Besides, the FDA says that those infections are relatively rare. But I think that we have to think about that in the future. So, do we need the disposable instrument for the ERCP and ERCP and endoscopic ultrasound? I think that we don't need it now, but I think that we need the common accessories for those two procedures. What does it mean? That means that we have to save money, especially for in the terms of the endoscopic retrograde pancreatography. And there is a huge cross-sectional study from Moitz in America with almost 500,000 of the patients, where they found that the predominantly ERCPs are graded in grade 1 and grade 2. Grade 1 and the grade 2 is something that we advanced ERCP divided this in four grades, and these two first grades are the easiest one, and they are not burdened so much with the complications. So those be outpatients. And another paraphrases is that we have to train our fellows and have to be straight in that. It is no longer driven by the number of the procedures, but the competency. And several studies have recently been published that suggest that some endoscopists reach 90 and 95% of the competency for a stone retrieval and stent placement after 200 procedures. But somebody after 100 procedure is not good enough for that. So for those cases for grade 3 and 4, we have to have experience and high volume center for doing that. So we have to train our fellows also for the endoscopic ultrasound and ERCP as well, and that has to be in dedicated hybrid operating room, one-stop shop. What is very important. On the very end, I can say that this categorization between the endoscopic ultrasound and ERCPs is very important. What I said, it means facilitates or to replace ERCP, and also we have to think about our training, and that's an important issue. Thank you very much.
Thank you, Professor, for this elegant talk. If there is any questions in the floor for the professor. Thank you, Professor, for this elegant meeting, and I hope to see you here in Cairo in the next year. We are happy for this elegant talk, and thank you again.
Thank you.
Thank you. And now we'll come to the end of the session. Thank you very much.
We will now announce the best abstract. We had 28 abstracts submitted to the Congress, and they were evaluated by 4 or 5 reviewers. The best abstract was titled "The Association Between the Circulating MicroRNAs as Predictive Biomarkers for Non-Alcoholic Fatty Liver Disease," and the corresponding author or the presenter is Dr. Mohammed Abd Samia. Thank you.
بسم الله الرحمن الرحيم. انا عارف انكم كلكم اكزهوستد وجبتوا اخركم، فانا مش هطول عليكم. البيريودز اوف ذا داي بس نقولها بسرعه كده وبعدين نختم على طول. المحاضرات اللي كانت عندنا النهارده ادفانسد النافل، دي اول سيشن. تاني محاضره دايابيتس اند ليفر، challenge in liver disease management, advanced in endoscopy, challenges in liver transplantation. آخر سيشن كانت AUS advances. أول محاضرة كانت بروفيسور مارك سودر، assessment of patients with NAFLD, FIV4 NAFLD, MRI elastography, advances in NAFLD by Professor Terry. NAFLD, MAFLD, crosstalk. MAFLD definition is more practical for identifying patients with fatty liver disease with a high risk of disease progression. This revised nomenclature appears to have essential advantages for diagnosis, patient management, therapeutic development, and public health awareness. Update of the nomenclature can only be the first step and should build the basis for new researches. Subphenotyping patients with MAFLD is mandatory in order to drive precise patient management and create effective treatment. Advances in NAFLD by Professor William Zawi. NAFLD are, we asking the right question, NAFLD versus MAFLD. Professor Dr. Hanaa Badran, advances in nutrition in NAFLD, food and NAFLD pathogenesis, diet for NAFLD, best diet for NAFLD, how to overcome diet failure. Diabetes and the liver by Dr. Shaima. Guidelines in the management of diabetes, intensification of treatment for patients with type 2 diabetes, not meeting treatment goals should not be delayed. The medication regimen should be re-evaluated every 3 to 6 months and adjusted. Diabetes and the liver, diabetes and the NAFLD by Professor Hassan al-Shinawi. In conclusion, the relationship between NAFLD and type 2 diabetes is so tight and complex that it's difficult to distinguish which is the consequence and which is the cause. Type 2 diabetes provides with an optimal metabolic condition for NAFLD progression, while NAFLD may in turn promote the risk of type 2 diabetes. The coexistence of NAFLD and type 2 diabetes has synergistic effect on each disease progression and complication, as NAFLD and type 2 diabetes are both considered risk factors for each other. This makes make us attentive to the optional impact of early screening of one disease in the previous presence of the other. Professor Demod Gleason, stopping immunosuppressive treatment in autoimmune hepatitis, it is justified, and in whom and when. Professor Martina Muller, acute and non-chronic liver disease, definition, decompensated cirrhosis, prevalence and mortality, precipitating factors, diagnosis and treatment. Application of artificial intelligence in liver disease by Professor Iman Abdessamia. All research is rapidly progressing, and it would be vital for hepatologists to understand and incorporate all models as helpful tools that can assist clinical decision making and lead to improved care of patients. Tips and tricks in cholangiography, a based approach by third space endoscopy by Professor Mohan. Eosinophilic esophagitis by Professor Ali Gaballa. The last session was challenges in rejection management post-liver transplantation, Professor Mona Al-Amir. Liver transplantation for malignancies expanding criteria by Professor Asma Goma. COVID-19 vaccines post-liver transplant by Professor Khalid Amir. EOS guided biopsy from the past to the future by Professor Peter Villman. How EOS and ERCP are upgraded by Professor Nadan Rajtumov. I want to thank all my professors and my colleagues who chair me in this conference. I think we satisfy all the needs of young colleagues and give them a good meal of knowledge. And thanks all the staff members in National Liver Institute for the success of this conference, which is made in a difficult time. But I hope you all get used of this conference, and and we satisfy all your needs about all subjects in hepatology and gastroenterology and endoscopy. Thanks a lot, all of your attendance, and hoping to see you next year, inshallah.
بنستأذن حضراتكم يا فندم، الهاندس اون شغاله دلوقتي، اللي يحب يحضر هنضطر بس نفضي القاعه ربع ساعه وبعدين نرجع للغدا. شكرا جزيلا.